So what we're going to do is we're going to do a live discussion on each topic. Let's say, I'll give an example. On September 1st, imagine that we're going to do anatomy, okay? So we are going to do anatomy from morning around 8:39 to evening 6:37 in 2 sessions. The morning will be the live discussion of all the questions of these high-heeled, hot competency areas of INI-CET going in depth. And then we'll stop it by evening, around 2 more hours left as a second session, where we'll take all the images alone in asked in the last 5 years in INI-CET and the entire subject together and discuss the images alone to give you a focus on image-based questions and the applications around these topics. So it will be 2 parts in the bootcamp. One is the hardcore competency review of the entire subject, connecting you to each and every topic, and then a second smaller session of discussing all the images of the particular subject. Understood? So that is what is done on the day 1, and then you'll get 2 days to study. Like after first day anatomy, 2 days to revise or 1 day to revise anatomy by yourself from your primary notes, so that you can make sure that you get the 130 base correct. Understood? If not, studying this high yield area alone will never get you INI-CET. You have to make your fundamentals and basics strong and revise everything up. It's very, very important. Understood? So you do that 1 day revision and then you write the anatomy exam on the second day evening in the Medico app. And the next day, let's say if it is dermatology, 1 day dermatology, same thing. Morning the competency review topic question discussion, evening the image-based question discussion. Next day, time for you to study by yourself, evening exam. Then it's 2 days medicine. 2 days we'll discuss all the systems like this. Morning we will discuss the competency review topics. After that, evening image discussions. 2 to 3 days holiday, and third day evening exam. So that you are having a revision track to come back to your original notes, understand these are the areas to study, focus and learn more or go deeper. Also review a quick review of all the images and topics in the subject and making sure you touch your base notes completely, so that you're going to improve from week on week. So how do we assess that? Every week there will be an INI-CET mock test happening in Medico app, which you can come in and take, so that you will understand your score is improving or not.
Hello everyone, a very good morning. I am Dr. Mallikeshwar Raja, an orthopedic and spine surgeon. I am going to be your faculty for today's session of INI-CET Bootcamp. My goal here is to make you guys follow orthopedics in a systematic way so that you're able to solve all the questions from orthopedics. Unlike other subjects where it can be tricky even for conceptual based questions to get everything correct, in ortho, if you're going in a systematic way, there is no chance for you guys to miss even a single question. Okay guys, come with me. Let's begin the journey for INI-CET Bootcamp. The first question, let's go from basics and then progress to advanced. Okay. So the first question, which of the following is a pathognomic sign of a long bone fracture? Okay. All these will be there when the fracture is there. Pain on the moment, yes, definitely it will be there. Swelling is going to be there. Deformity is going to be there. But what is the pathognomic sign? The sign for a fracture is abnormal mobility. The answer for this question is abnormal mobility. Let us discuss a few important one-liners. Trust me, my class is not going to have a lot of one-liners or mnemonics. It's not what you guys need. What you guys need is concepts. Okay. So, the most common pathognomic sign for a fracture is abnormal mobility. The most common symptom is going to be pain. The most common sign is going to be swelling. Okay. Let's have a few discussion regarding the fracture and the questions which can come from that. Okay. What is a fracture? A fracture is a break in the continuity of the cortex and the medullary cavity. Don't miss out on that. Okay. Based on the classification, what I have divided that into the, depending on the intensity of the trauma, how we can classify fractures and why, because many questions are coming from this. Okay. So just stay with me. Okay. So based on the type of trauma, if you take the trauma to be a significant one, okay, what do you mean by significant is the led to high velocity injury. Okay, if it is a significant trauma, you get the typical fracture patterns. What are all the typical fracture patterns? The transverse type, oblique type, spiral type, all these are the typical fracture patterns. If the force or the trauma is insignificant, okay, then there are two possibilities, okay. If the insignificant force is occurring on a normal bone on a repeated manner, you get something that is called as a stress fracture. If the insignificant force is occurring on an abnormal bone, you get a pathological fracture. Why this mechanism is important is because just with the clues in the question, you will be able to differentiate between a pathological fracture or a stress fracture and directly arrive at the answer. All right. If for what are the examples for an abnormal bone? It could be an infective disease bone, a bone tumor might be there, or a metabolic bone disease could be there. All these are examples of an abnormal bone. All right. So, like I discussed before, what are all the injury patterns based on a significant trauma? All right. First one is a transverse fracture that occurs due to a tensile force. An oblique fracture that can occur because of a compression force. An oblique fracture can get displaced when there is a shear force. All right. A spiral fracture can occur when you have a twisting force, or when the force is like direct heavy force, you get something called as a comminuted fracture. All right. Okay. Next question, guys. A 25-year-old male is playing football with his friends and lands on an outstretched arm. He is seen in the emergency department and radiographs are obtained in the figure A. He is taken to the operation theatre for open reduction internal fixation and post-op imaging is given. Which is true in regard to the fixation achieved? All right, a simple question, but the options I have made it difficult for you guys. Okay, the fracture is what? A transverse type. What have they done? They have done a plating with screws. Okay. Now the question they're trying to reach, what kind of fixation we have achieved or what kind of healing we are trying to achieve. Relies on enchondral ossification. The fracture site strain is 2 to 10%. Soft callus is eventually covered to hard callus or occurs via Haversian remodeling. Okay. They're asking about bone healing. All right. The bone healing, the answer for this question is primary bone healing and the answer is Haversian remodeling. Now let us discuss a few points about the bone healing so that you will know how to tackle such questions. All right. All right. If we look at the fracture healing, there are two types. Okay. Primary fracture healing or the secondary one. The primary fracture healing, what you guys have to understand that there is going to be direct bone to bone contact and no callus is going to be there and there are going to be no micro movements. This will be achieved when you are trying to fix the bone using absolute stability. Example, typical example for an absolute stability device is plates and screws. Okay. So for that question, I guess you will understand the concept now. We are using plates and screws. There is no gap between the fracture site. We have given absolute stability. So the answer is primary healing via Haversian remodeling. Okay. If you look at secondary healing, there is going to be callus formation. There is going to be micro movements at the fracture site and how we do it using IMIL nailing, which in turn will provide a relative stability. All right, guys. So what I want you guys to understand here is, see, for the same fracture I say, they're using plates and screws, no gap in the fracture site, so primary. Whereas, if I have used a IMIL nail or a K-wire, there will be some amount of gap with bridging callus. In that case, you go for secondary healing. All right. So that's how we differentiate between absolute stability and relative stability. All right. Both will unite the bone. Okay. But it is very important to choose like which type of fracture to be fixed with what stability. That is not required. But what is required is for you guys to identify the fixation correctly. All right. Look at this question also. A 45-year-old man presents with a femur fracture following a road traffic accident. All right. After 6 weeks of conservative management, X-ray shows the following finding. What stage of fracture healing is the patient in? Okay. The answer for this question is the reparative phase. Now let us discuss a few points regarding fracture healing. Okay. See guys, here I want you guys to understand that just like any other tissues in the body, the bone also has the potential to repair itself. Okay, the body continuously tries to repair all the organs. Similarly, the bone also is able to repair. But the reparative phase or the healing phase of the bone takes place over a wide duration of time. And based on that, they ask you a lot of questions. All right, so just stay with me. I've tried to simplify it as much as possible. All right. If you divide the stages, and to easy remembrance, I have kept it as 2 to 2. Okay, 2 to 3 days would be the hematoma formation or the inflammatory phase. That is predominantly dominated by platelets and neutrophils. So in the question, usually they ask which is the first type of cells to occur in the inflammatory phase. Don't put it as neutrophils, rather platelets becomes the first and then comes the neutrophils. Okay. From 2 to 3 weeks up till 2 to 3 months, you can put it like even up to 6 months, you can put it like the reparative phase. Okay. There will be neutrophils will be present and macrophages are going to be present. Beyond 2 to 3 years or more than 3 years is when you are going to have the remodeling phase. When it has entered the remodeling, these acute inflammatory cells are going to come down and chronic inflammatory cells, for example, T and B lymphocytes are going to predominate. Okay, this is very important. And the first stage of union in the X-ray, we'll be able to see the callus, that is actually the soft callus, at around 3 weeks. Okay, I hope now you would have been able to understand why this is reparative phase, okay, and not an inflammatory phase. The inflammatory phase predominantly in the first 2 to 3 weeks. Beyond that is the reparative phase. Okay, yes. Let's look at this question. The figure A in the radiograph of a 52-year-old male who underwent open reduction internal fixation of a both bone forearm fracture 9 months prior. He complains of persistent pain at the ulna fracture site. His C-reactive protein and erythrocyte sedimentation rate are within normal limits. What is the most appropriate definitive treatment? Now look here, based on the knowledge, let's say they have tried to use plates. That means they have tried to achieve absolute stability. In that case, there should not be any gap between the fracture and no callus. Okay, this is what we know. But here, even after 9 months, there is a gap at the fracture site. That means there is some problem regarding bone union. For this 9 months is a very important terminology. Okay, just like any other specialty or any other field for that factor, we always feel when we do things in the right intention, we expect the results also to come to us in the right way. But life is never like that. Okay, there are several external factors or internal factors that is going to affect the result, right? Just like your preparation phase. Here also, even though the doctor has tried to achieve absolute stability by using a proper plates and screws, because of some reason, it could be the patient could have given weight much earlier or any other reason, there has somehow occurred a gap. Okay, and if the gap is not uniting for 9 months, that is the golden period up to which we can wait and watch. We call it as a non-union. All right. So in this case, what we have to do, this is an example for an atrophic type of non-union where there is no potential for new bone formation even after 9 months. So we'll have to do a revision plate fixation, open reduction internal fixation with a bone graft. What is this bone graft going to do? Bone graft is going to give that new bone, is going to give that extra push. All right. So that is what is required. So next question, similar to non-union. Which of the following substance is used for bone formation in patients with non-union? Here, substances, what we have to understand is certain substances has bone supporting capacity. So only certain substances has bone induction capacity. A simple cement all will be a bone supporting device. So something that has bone inductive property is a bone morphogenic proteins or BMPs. So the answer for this question is bone morphogenic proteins. So let's have few discussion regarding a bone union. Okay. So up till 6 months, we have termed it as a delayed union. If only after 9 months there's not going to be any callus formation or any signs of union or signs of non-union, we are going to give the term as non-union. The most common bone that suffers from non-union is tibia, and the most common site is diaphysis. What are the types of non-union? It could be hypertrophic, oligotrophic, or atrophic. Why this is important is because how we are going to manage them. The management differs for these types of non-union. What we have to understand regarding this hypertrophic non-union is that, as the name implies, there's going to be lot of callus. So what does that callus indicate? It indicates that the bone is able to form. Okay, we are having this bone induction, but the thing is it is not happening in the correct place. So for that, we'll have to only focus on this inadequate fixation. So you'll have to fix it with better stability because good biology is there. Whereas in atrophic non-union, what you see is the biology itself is very poor. So there is no bone induction there. So along with fixing with better stability, you will have to provide something with that extra push to give the new bone formation. So that is called as bone grafting. That could be BMPs, our iliac crest bone graft. So all this will give the new bone formation. Okay. All right. So one more question is there on this union. So let's solve this. A 50-year-old male with a history of smoking presents 8 months, all right, after a tibial fracture. X-ray finding is given below. What is the most likely diagnosis? Non-union. Now you will be even be able to say what type of non-union. So there is no callus at all. So it is mostly atrophic type of non-union. So see, once you know the concept behind that, solving the questions becomes simple. All right, next question. An elderly woman is brought to the OPD after she slipped and fell from her chair. She is known case of breast cancer with distant metastasis. The X-ray of the patient is given below. Which of the following statement is false? False. Okay. It occurs in abnormal bones. Okay. Previously, when I discussed an insignificant trauma, so just slip and fell from chair. Insignificant trauma on an abnormal bone. All right. It's a case of breast cancer is given. I already told tumor bones are example for abnormal bones. In that case, what do you expect? A pathological fracture. So the type of fracture here is a pathological fracture. So which of the statement is false? So it occurs in abnormal bones. This is true. Mirror score is used to assess the risk of fracture. Yes, for pathological or tumor based fractures, we always use mirror score. The PET scan is the gold standard evaluating in bone metastasis. Yes. Pain only occurs after the fracture. So this is the false statement. In pathological fracture, you will have to know that pain occurs before the fracture. It gives the warning. That means the bone is getting weaker and weaker and weaker, so that even on normal loading, you start getting pain. All right? Yeah. So regarding pathological fracture, how we discussed before, an insignificant trauma is occurring on an abnormal bone. Example is tumor, infection and metabolic bone diseases. The most common clinical feature is pain before the fracture. Investigation, first line of investigation is always the simpler ones, that is the X-ray, but you have to proceed with an MRI. But the gold standard for any pathological fracture is a biopsy. Most common location for a pathological fracture, if it's an osteoporosis, metabolic bone diseases, point dominates over hip. If it is a metastasis, the hip dominates over spine. That is proximal femur more than the spine. All right. Now let us solve this question. A young marathon runner is participating in a marathon competition. After running for about 100 meters, he develops pain at the anteromedial aspect of tibia, which was mild to start with but increased on further running. X-ray was abnormal. Here let's solve. The trauma, he's getting pain. So some insignificant trauma is there. Why? Because running again and again. So repeated on a normal bone. There is no signs of pathology. So doctor ordered a bone scan. What is the likely diagnosis? So where is the pain? It develops on the tibia. In the tibia, the stress fractures on the tibia are named as shin splints. Okay, so the answer for this question is a stress fracture of tibia called as shin splint. Look at another similar question. A 30-year-old marathon runner presents with pain in his shin after increasing training intensity. X-ray finding is given below. What type of fracture? It is a stress fracture. All right. See, based on the concept of stress fracture, they have given two different questions. All right. So see, this fracture, even one more clue you can have is it will usually be an incomplete. Incomplete, I mean, is the entire cortex to cortex length will not be affected. Okay. It will usually start at one side of the cortex, the other will be normal, and it will go here. This will be intact or not broken. So in such cases, you can undoubtedly go for stress fractures. Okay. Few words about stress fractures. Repeated, in the question, these should be there. Repeated insignificant trauma on a normal bone. It's also known as a fatigue fracture. The most common bone again is tibia. The most common bone in the foot is second metatarsal neck, which is known as March fracture, more than the third metatarsal. Investigation is the first line is always an X-ray followed by MRI, which becomes a gold standard here. The management is usually a conservative management is enough. This is an example for a stress fracture or a March fracture. Okay. Next question. Which of the following bone cells is responsible for secreting the bone matrix? Let's discuss, since a lot of questions in INI-CET is based on the histology, I thought to give you guys a brief things about histology so that you are able to recognize the cells. Okay. If they give this kind of a picture, always remember guys, osteoclasts are, giant cells, giant cells. They are the macrophages, they eat the bones, okay. So these giant looking cells are basically the osteoclasts. They are responsible for bone remodeling, characterized by increased TRAP. The cells which are on the borders or the bone forming cells are the osteoblasts. They are characterized by increase in ALP. When these osteoblasts have used all their energy, they become old. They settle down in the matrix like forming osteocytes. They are the spent osteoblasts. So the answer for this question is responsible for bone secretion is osteoblast. Okay. This is another histology picture to differentiate between a fully formed mature lamellar bone or an woven bone. See here, the entire bone, this pink color is fully formed. Here there are numerous gaps. Okay, that signifies if it's an immature bone or a mature bone or a simply to put as a well organized bone. All right. Now coming to the important things, management of trauma. Okay, based on these, every year you get one or two questions. Two basic concepts you'll have to understand. Okay, what do you do with a isolated monotrauma or if it is a polytrauma? In polytrauma, is the patient stable or unstable? If you get this concept correct, you will never go wrong in the questions. So I have given plenty of questions because every year this concept is tested to make you guys thorough with the concept of polytrauma and monotrauma. Okay, play close attention. Okay. In the management of trauma, the patient has arrived in casualty. As usual, for all trauma patients, you follow the ATLS guidelines. That is A, B, C, D, E you have. A is you check the airway, B is breathing, C circulation, and then you go for disability. In the disability is where you come to ortho. I am isolating this for orthopedic discussions. Okay. If it's an isolated ortho trauma or if it's a polytrauma. First, let's look about isolated ortho trauma. Which bone is affected, what is the deformity, and what is the neurovascular status. To find out about this, you're going to send for investigations. It could be X-ray, CT or MRI as and when required. If it is a case of polytrauma, if it is an unstable one, you will have to remember the concept of damage control orthopedics. What is damage control orthopedics is you don't try to fix everything at the one go because there is a high risk of ARDS. Already the patient has numerous injuries. In that case, if you try to fix the bone, always remember guys, a surgery is again an injury causing an injury to the bone. So already the body is undergoing so much of injury, so all the inflammatory markers will be at full force. So again, when you take up the patient for surgery causing new injury, the body will not be able to handle it. Okay. So that is why they have come up with a terminology called as damage control orthopedics. Earlier it was ECO, earliest complete orthopedic care, but now they have changed it to DCO. Okay, damage control orthopedics. I'll tell you, how do you define a polytrauma? when the injury severity score is greater than 40, if there is no thoracic injury. If the injury severity score is greater than 20, but a thoracic injury is present. The GCS is less than 8, hypothermia less than 25 degrees, abdominal chest trauma or bilateral femur fractures. In that case, for 2 to 5 days, you will have this acute inflammatory products. Till then, only life-threatening injuries has to be handled. If the orthopedics injury is there, you can go with an X-fix or a temporary stabilization. Only after the patient has become stable, you are going to go ahead with a definitive fixation. Okay. So, what are the definitive fixation timelines is 7 to 10 days for pelvis and tibia. Till then, you're going to keep an X-fix and then only convert to nail and plates. Up to 3 weeks, you can wait for a femur on an X-fix. Okay. If the same is a polytrauma occurring for an open fracture, the golden hour is 6 hours. But one keyword which you have to remember is the 6 hours is for preventing infection. Okay. But for definitive fixation, you can go up to 72 hours. Okay. So the first procedure would be to debride within 6 hours, use a negative suction for the wounds and put him on an X-fix. And after the patient becomes stable, you can take it up for definitive fixation and soft tissue cover. This is a clear example of using X-fix, vacuum dressing for a open wound, and once it is all healed, you can take it up for a definitive fixation. That's how stage procedures you do. Okay. So, what is the common classification we use for open fractures? It is going to be the Gustello-Anderson fracture classification. And based on this Gustello-Anderson itself, you will be getting a lot of questions. So, the easiest way to remember Gustello-Anderson is based on the wound size. Okay. Type 1 is wound is less than 1 centimeter. Type 2, the wound is 1 to 10 centimeter. Type 3, the wound is greater than 10 centimeter. In type 3 only, there are differences like A, B and C subclassification. C is very simple. If there is a neurovascular injury, you put it as C. That becomes the highest priority. How to differentiate between A and B is slightly tricky. Both are about 10. But if the contamination is very much higher without a neurovascular injury, you put it under type B, or in the other case, you put it under type A. Okay. The most common bone to undergo an open fracture is tibia. The most common complication after an open fracture is going to be infection. And let's solve a few questions based on this so that you guys become very thorough. Okay. A 35-year-old man is brought to the emergency department following a high-speed motor vehicle accident. He is unresponsive and has multiple injuries. This is polytrauma and he is unstable. Alright. So, he has a suspected femoral fracture is there, abdominal bruising is there, abdominal is blood pressure is 90-60, heart rate is there. So, tachy with the hypotension. So, all points was unstable. So, what is the first step? So, patient is in going for hypovolemic shock. So, what will be the first step? Can we shift the patient for the x-ray of the femur? No, the patient is going to collapse. Do we have to do fast? Yes, you have to do, but before that, you will have to do something for the falling BP. So, the best option for this would be the intravenous fluid resuscitation. And then simultaneously, you can do a fast rule of the abdominal bruising and then put a splint, for example, a Thomas splint for the femur fracture and then shift him for the further x-rays after he has become stable. Okay. Next question. A 40-year-old man is rescued after being trapped under a collapsed building for 8 hours following an earthquake. He complains of severe pain in his legs and there is swelling and bruising in both limbs. Okay. So, this is like a trauma is there. Usually, it is like a monotrauma only, not a polytrauma. On arrival, but his urine is dark and blood test shows elevated serum creatinine and potassium. Here, what is this is? There is increased muscle damage. Okay. The patient is going for tissue necrosis. Hence, for tissue necrosis becomes very important to manage correctly. Okay. When the patient is going for tissue necrosis, you will have to do when the creatinine has become very much elevated, immediately you will have to do a IV fluids and then perform if required a dialysis. The answer for this question is what is the most important next step would be Not answer D. It would be answer B. Start fluids immediately and then if required to go for a dialysis. Please make a small note in the modules that is going to be handed over to you. The first step, immediate first step is going to be fluids and then only you're going to do a dialysis. Okay, this is a example of this condition is called as a crush syndrome. Okay. Next question. A 28-year-old motorcyclist presents to the emergency department after a road traffic accident. His tibia is visibly fractured and the bone is protruding through the skin with significant bleeding. This is an example for an open fracture. A neurovascular is intact. What is the immediate priority in managing? Immediate surgical fixation? No. We have 6 hours. What is the immediate priority is start broad spectrum antibiotics because the most common complication is going to be infection, what we have already discussed. All right. Next question. A 35-year-old man presents with an open fracture of the femur after a fall from the height. Again, an open fracture. Okay. The wound is contaminated with dirt and the femur is visibly fractured. Her vitals are stable. So, this is also a stable open fracture. Okay. What is the next best step in managing this open fracture? So, what I have done, you will have to usually debride and put an X-fix to prevent infection. So, the answer is an external fixation. Look at this question, okay. A 45-year-old man presents after a traumatic amputation of his right hand following an industrial accident, okay. An open injury but industrial wise. He is hemodynamically stable, okay, and the amputated part has been brought to the hospital wrapped in a moist gas. What is the next best step in managing this patient? See here, the open fracture has been amputated. So, like we discussed before, what is the next best immediate step? If the patient was hemodynamically unstable, you would be starting fluids. But he is hemodynamically stable. So, what is the next best thing? To start an IV antibiotics to prevent infection because the most common complication is infection. Okay. Look at this question. A 32-year-old cyclist presents after a fall. He complains of pain and deformity over the middle third of the clavicle. On examination, there is crepitus and obvious deformity. Okay. The patient also complains of numbness in the hand and his radial pulse is diminished. That means it is a closed injury only, but neurovascular is affected. Then this becomes an emergency where you have to do an open reduction internal fixation and get a vascular surgery consult. Okay. See, there is numbness and also his radial pulse is diminished. Okay. In that case, you will have to open this, free the fragments and fix this, followed by a vascular surgeon consultation. Okay. Next question. A 35-year-old patient sustains an open tibia fracture of significant soft tissue injury. The decision is to perform an operative treatment is taken. What is the recommended time for definitive fixation? Don't confuse this. If they were given an immediate fixation, you can put within 24 hours or 6 hours. So, what is the recommended for definitive operated fixation is within 72 hours after the infection settles. Okay. Only for polytrauma, we said it can wait up to 2 weeks. This is infection. If the infection is settling, we can take up for definitive fixation within 72 hours. Okay. Okay. Hope you guys are clear with this concept of how to treat monotrauma, polytrauma. If the polytrauma is open or closed. See, monotrauma, isolated injury, you can definitely go in for a definitive fixation. Polytrauma, you wait for the other things to heal. That is for 2 to 5 days and then think of fixing the orthopedic fractures. Till then, you can put an X-fix. If it is a case of infection, immediate within 6 hours should be to debride and X-fix. And definitive fixation after 72 hours, up to 2 weeks, you can do it. Okay, guys? I hope very simply, this is the algorithm to manage a open trauma and a polytrauma. All right? All right. Look at this question. A 22-year-old female falls off the back of a motorcycle and sustains an injury shown in figure A. What is this injury? It is a type of open book type with pubic diastasis. See, there is increased space between the pubic symphysis. What is they're asking is, what is the correct ratio of transfusion of platelets to platelets and plasma? The correct ratio for hemodynamic stability is 1:1:1. Not just flush in with the RBCs or the whole blood. Okay, you need ratio of everything, plasma or constituents, because otherwise the patient will go for DIC, disseminated intravascular coagulation. Okay, that's why you need to give the ratio of 1:1:1. Okay. Next question. This will help you apply the concept what we have read till now. Alright. A 23-year-old male arrives in the trauma bay after a motorcycle crash caused by a drive-by shooting. Okay. The patient is awake and alert. Okay. And vital signs and lactate levels are stable. So it is a stable injury, not unstable. The patient is grossly neurovascularly intact with a 6 centimeter transverse ragged wound over the medial ankle. So open ankle injury, and the other fractures are closed. So he has a closed tibia, and what is the other injury? Femur. So it's an open ankle and closed tibia femur. So ideally for a stable patient, what we will do? For open tibia, you are going to debride and put an X fix. For tibia and femur, you are going to do a definitive fixation. A definitive fixation for femur and tibia is going to be IMIL nailing. Okay. So look at this. Look at the options. Okay. So the options is irrigation, debridement and placement, external fixator right tibia, intramedullary fixation of femur and tibia. This is going to be the answer for this question. Okay. So if you apply this concept and first itself divide open injury, stable or unstable, monotrauma or polytrauma, and then you will never go wrong in these questions. Okay. Few more questions to help you guys get clear with this concept. Okay. Every year questions comes from this, guys. Don't miss out on this. Okay. A 36-year-old woman presents with a grade 3 open midshaft fractures as a result of high-speed motor vehicle collision. So it is an open grade 3. You cannot do immediate definitive fixation. That's what should come to your mind. Concomitant injuries include a high-grade splenic laceration requiring splenectomy, subdural hematoma. So this is a polytrauma. And patient is unstable. There is splenic injury, subdural hematoma, GCS will be low. Okay. Which of the following is the most appropriate management of the femoral shaft fractures? Guys, tell me it's an open injury. So, and polytrauma. What we have to do? Debride and place an X fix. Never attempt a definitive fixation. Okay. So, placement of an external fixator. Alright. Well, and debridement. If the patient is more unstable, this is what we'll have to do. Okay. Look at this question. A 40-year-old man presents with fracture of the right tibia following a road traffic accident. On examination, the wound is highly contaminated and appears as shown below. His distal pulses are felt well. According to Gustlow-Anderson, this would be. Gustlow-Anderson, what did I say? Less than 1 centimeter type 1, 1 to 10 centimeter type 2. So this wound is definitely more than 10 centimeters. So it's type 3. They have said highly contamination, but distal pulses are felt well. So it is type B. So Gustlow-Anderson type 3, B is the answer. Okay. Now look at this question. A 51-year-old male presents to the trauma bay as a level 1 trauma following a workplace injury. It is completely crushed. A mangled extremity score of 9 is given. MES score. What is MES score? Is to decide for amputation. See, this MES score you need not by heart, guys. Don't think about by hearting scores. This is going to be available in a printed format in a good emergency department. Just you need to see it and give tick marks. If the MES score is less than or equal to 6, you can try of salvage. If the MES is greater than or equal to 7, you will have to use and go ahead with amputation. So what is the most important significance of this MES score is, see, with the MES score, we are going to decide something life-threatening. A patient is going to lose his limb permanently. At that moment, you want more specificity than sensitivity. So a MES score is highly specific but with less sensitivity. And the key thing to remember about MES score is minimum 2 consultant opinions are needed to determine the MES score. So high specificity and low sensitivity. Okay. What all the variables are present in the MES scores are injury type, shock, ischemia and age. These are the factors based on which MES score is divided. Need not by heart the entire MES score. Okay. Few points regarding amputations. Okay. Regarding amputation, the indications are usually a dead limb, dangerous limb or dumb limb. A dead limb means it is already, there is no neurovascular supply and it is gone. A dangerous limb where there may be an impending gangrene, impending infection. A dumb limb means which is completely there's no neurology and the limb holds no purpose for the patient and it is disturbing his day-to-day life or getting frequently injured, which can develop necrosis. Okay, all these are indicative for amputation. Based on the principles of amputation, few questions can come. So I'll just discuss them in brief. Okay, all the salient features. Types are there, guillotine type and primary closed. If it's an infective case or a tumor case, never try to achieve primary closure. Okay, always do a guillotine and leave an open end. Wait for 2-3 days and then take up for definitive fixation. Whereas in a trauma, if it is a clear-cut injury, you can plan for definitive closure. That is primarily closed. A tourniquet has to be avoided in the case of infection and peripheral vascular disease. Muscle, how do we use the muscle? Okay, see, muscle to muscle or muscle to the bone. A muscle to muscle is the best chance for achieving vascularity. Bone has relatively less blood supply than the muscle. So, a muscle to the bone, that is myodesis, is contraindicated in peripheral vascular disease where the main problem is blood supply. You will have to use muscle plasty, that is muscle to muscle. Okay. The bone cutting is always 5 centimeters shorter than the skin and closure can be fish type or scoot type. Okay. So, important named amputations are for the forearm, it could be Krukenberg tumor. In the foot and ankle, above the ankle joint is Symes. At the level of ankle joint is Boyd and Pirgoff. Intertarsal is Chopart. Tarsometatarsal is Lisfranc. The most common complications are going to be neuroma, in which case we'll have to excise it. Neuroma means the nerves which are getting injured at the end, they'll go for a neuro. You'll have to excite it, otherwise they'll be very painful. Or the well famous phantom limb. For that, mirror therapy is usually adequate type of management. Okay. Next type of question is, what is a degloving injury? Let's look at the degloving injury. It is also known as a moral level lesion where the separation of dermis from the fascia occurs. Okay. So, most common type is RTA, usually by vehicle tire running over. You see, when the vehicle tire is brushing over it, it pulls the skin and the subcutaneous tissue, right, from the fascia. Where does the skin and the subcutaneous tissue get the energy from? Or the nutrition is from the fascia and the underlying blood supply. Okay, those are the major supplies. So, when they are separated, that becomes a dead space and will lead to infection. Okay. So, best option management would be open debridement and delayed wound closure. This would be the typical exam picture where you have a large contusion or a bruise but with fluid fluctuation because one layer is separated and there is dead space in between. That will cause a fluid fluctuation. How you test for in knee tap or in ascites. You tap on one side, you have the feeling on the fluid on the other side. Okay. That is an example for moral level lesion, okay, or degloving injury. Next specific type of injury what they can ask you is the compartment syndrome, okay. So, in compartment syndrome, what you guys should know is, see, the muscles are covered by shirt-like things called as fascias. There are several muscles like muscles. So, each muscle in the upper limb and the lower limb will have a separate compartment. For example, in the house, you will have one room for your brother, one room for your sister, one room for parents. Each room is covered by the doors and the windows. Imagine one particular room alone, the doors and windows are shut for a long time and there is no exhaust. That means inside will all be suffocating because oxygen supply will decrease. The same thing happens in the compartment. Because of the injury, the one particular compartment will be deprived of the blood supply, leading to decreased saturation of oxygen. Okay, that's how oxygen reaches the blood tissue, leading to an increase in intracompartment pressure. Okay, the normal is around 5 to 15. Okay, in compartment it can go up to 35 to 45. The most common fracture is always proximal tibia fracture. The clinical features, always remember guys, 5 P's. Okay, pain on passive extension, loss of pulse, pallor, paresthesia and paralysis. Paralysis is the last to come, and most characteristic is the pain on passive extension. Okay, so the surgery for this is you'll have to proceed with an immediate fasciectomy. Okay, next question. Tibial fracture, after 12 hours he becomes unconscious. Axillary petechial lesion, breathlessness is a diagnosis. See guys, all this compartment syndrome, degloving injuries occur immediately. If in the question you get something like after 12 hours, if the patient is becoming sick, always think of fat embolism. In a case of long bone fracture, fat embolism for long bone fracture. We all know that there is marrow inside the long bone diaphysis. From the marrow, all these fat globules can escape out. They can enter the circulation and go and cause an emboli in the particular vessels. It can lead to breathing difficulty, or periphery, it can lead to ecchymosis and stuff. Okay, that is a typical occurrence after 12 hours, usually self-limiting 12 to 72 hours. We have to give only supportive measures. Okay, the answer is fat embolism syndrome. Okay. So the first two topics are done. Next we'll come back and finish off the next topic. Okay. Okay. Now pay attention to the next topic. Okay. Look at this question. A 59-year-old right-hand dominant male carpenter sustains the injury shown in figure A. He has no history of chronic shoulder pain, has never had a surgical procedure on the shoulder. Okay. So what is this fracture? It's an example for proximal humerus fracture. Okay. You see the patient complete your exam and this is a solitary injury. Which of the following is the best indication for doing hemiarthroplasty? Guys, first, this proximal humerus fracture, we used to fix it with something called as Philose plate only. But you know that neck of femur fracture, we have to go for replacement. Okay. So, but in Philose plate, what happened was when it is severely comminuted, the results were not that good. Hence, we started doing hemiarthroplasty for shoulder also. Okay. But which is the characteristic thing that determines the indication for hemiarthroplasty is going to be the head split pattern. If the head split pattern is there, you have to do a partial shoulder replacement or a total shoulder replacement 100%, because fixing it with the Philose plate will end up in failure. Okay, I hope this is clear. So few points regarding the proximal humerus fracture. The named classification is Nace classification. He has given like 1 part, 2 part and 3 part depending on the fracture fragments. Okay, if the fracture fragment involves only the greater tuberosity, or it could be the fragments are lesser tuberosity, the head and the shaft, these form the parts. Based on how many parts are displaced, it can be a 1 part fracture, 2 part fracture, 3 part fracture and 4 part fracture. Among the 4 part fracture, with there's a head split pattern, you'll have to do an arthroplasty. Up till 3 parts you can do with a Philose plate. Okay, beyond that, using a Philose plate, the results are not that good. Okay. Other important fractures, even though we are doing only test and discussion, I still felt that it will be incomplete to not touch upon the other fractures. Just the important concepts I want you guys to be thorough with. Okay. So other important fractures, it could be the clavicle fracture. This is the most common fracture at the birth, the newborn. The medial fragment is pulled up by the sternocleidomastoid. The lateral fragment is pulled down by the pectoralis major and the weight. So the most common site is between the mid-third and the lateral two-thirds. Only operate if it is open or a neurovascular injury, where we have already solved the question based on that. Okay. The other upper limb is the humerus shaft fracture. We'll all know The middle third fracture will lead to radial nerve palsy. And one more important type is a distal third one called as a Holstein-Lewis. Here also you'll have a radial nerve injury, but it is not occurring at the time of the fracture. Rather, when we try to reduce the fracture, that is when this radial nerve injury occurs. It is a iatrogenic fracture leading to radial nerve injury. Okay? Yes, we'll have a short break and get back. Welcome back, guys. Next question. A 62-year-old insulin-dependent diabetic male has had 4 months of atraumatic right shoulder pain and loss of motion. With this itself, you guys will know the diagnosis it as frozen shoulder or PA, periarthritis shoulder. Okay. So what they want to test you here is, on examination, he has loss of active and passive external rotation. This is the characteristic of frozen shoulder. He has previously undergone physical therapy and an injection. He is interested in undergoing arthroscopic capsular release. In addressing expectations, which of below is the most accurate one? Most accurate. Okay. Axillary injury is the most common complication. No, that is a very rare complication. Post-operative improvements are maintained at long-term follow-up. Yes, definitely. Release of the posterior capsule alleviates the most common area of stiffness. No. The most common is the EGHL. Okay, superior glenohumeral ligament. Okay, so that is the most common cause of problem in a case of frozen shoulder, superior glenohumeral ligament. Okay, and residual stiffness is a rare complication. No, this is the first and the most common complication. So the answer for this question is post-operative improvements are maintained at long-term follow-up for both conservative and arthroscopic. Okay, few words about frozen shoulder. Frozen shoulder, also known as adhesive capsulitis or periarthritis shoulder, associated with diabetes, decrease in both active and passive ROM. Most common involved structure is the superior glenohumeral ligament. In the clinical, the most common finding would be the decreased external rotation, and the management would be from the conservative, that is physiotherapy, exercises. If it doesn't improve, you go for steroid or PRP injections, and then you move towards the manipulation and anesthesia or arthroscopic release. Okay, in all this, long-term results are good, but patient specific. Okay, depending on the patients. That's all. So you'll have to decide. Some respond well to PRP injection, some will respond well to steroid injection. For those cases who don't respond to that, you can do an arthroscopic release, which is a bit costlier procedure, but long-term results are good in all the things. All right. Look at this question. A 17-year-old male falls while snowboarding and sustains the injury depicted in figure A and B. Following closed reduction, the left elbow remains significantly unstable. Which surgical treating this? Which structure is most likely injured in this repair? What is this? This is an example for an elbow dislocation. In elbow dislocation, you can have it like either stable or unstable. The most common cause of unstable is the ulnar collateral ligament. But what you have to understand is, guys, what is the trick here is, ulnar collateral ligament is actually medial. You know, ulnar is medial side, right? But in ulnar collateral ligament itself, there are two things. Okay, medial ulnar collateral ligament or lateral ulnar collateral ligament. Among that, the most common injured is lateral ulnar collateral ligament. Don't confuse this lateral for radial. Okay, among the ulnar collateral ligament, the lateral part gets affected and that has to be repaired. Okay. Let's look at other few injuries that can occur around the elbow. So we are proceeding in upper limb. I'm covering everything from the clavicle to the proximal humerus, shaft of humerus, distal humerus, so that you get a complete understanding. All right. Even though this is a test and discussion, I want you guys to be thorough with all the questions that has come for in a systematic way, so that you don't miss out anything. So, okay. So this particular session should be more than enough for you guys to just revise before the exams and go get full marks. All right. So that is my aim. I hope all of you will do that. All right. So other important injuries around the elbow becomes the terrible triad injury. Triad. Okay. That's what you have to remember. So there's going to be posterior dislocation of the elbow. There's going to be a coronoid process fracture and radial head fracture. In this image, can you tell me which is the coronoid? So this is going to be the coronoid process. Along with this, you're going to have a radial head fracture. All these three are combined. It's definitely one of the worst injuries that can come. As a practicing surgeon, I'm going to have a headache fixing that also. Okay. So, terrible triad injury involves these three things. The ligament which is most commonly involved and causing problem is the lateral ulnar collateral ligament. The investigation of choice is to pick up the small coronoid fractures which gets missed with the X-ray is the CT scan. Okay, for treatment wise, for the radial head, you can either replace it or try to reconstruct it. For the ulnar collateral ligament, you will always have to reconstruct it. For the coronoid fracture, you can fix it using an Herbert screw. The most common complication becomes the stiffness or heterotrophic ossification. The other few fractures around the elbow would be the olecranon fractures, where if it's a simple fracture, you would do a 10-10 band wiring. If it's a comminuted fracture, you go ahead and do a plating. Okay, look at this example. So if we follow in a systematic way, the AIMS questions or the INICET questions becomes easier. A 50-year-old man presents with a direct blow to the posterior aspect of his elbow. He is unable to extend his elbow. X-ray shows fracture of the olecranon process. Which of the following is the most appropriate management? What is the big difficulty in questions? It becomes very simple, guys. If you forego area by area in a systematic way, you will never go wrong in these questions. Okay. So the answer already we have seen, it is open reduction internal fixation using tension band wiring. So that is the answer. All right. Next question. A 50-year-old handyman presents to your office with ongoing lateral elbow pain. He receives a cortisone injections 13 months ago and did 3 months of physiotherapy. He has developed lateral epicondyle. What is this lateral epicondyle? They are talking about tennis elbow. What structure is affected most? So, tennis elbow structure is the B, E extensor carpi radialis brevis. Okay, that is the most common structure that is affected at the attachment area. That is what we would usually target in both conservative or surgical. We will just release that muscle to prevent it from causing pain. Those are rare cases. Okay. The other things around the elbow is, one is the tennis elbow, lateral epicondylitis, ECRB is involved. The test of choice is Cosen's test. Treatment wise, you can put a steroid injection, PRP injection, or open ECRB release. If it is occurring in the medial epicondylitis, you term it as a golfer's elbow, where the inflamed structures is the flexor pronata mass. If it is occurring in the posterior around the olecranon, because the frequent of students keeping their elbows on the table, it's called as a student's elbow, characterized by olecranon bursitis. Okay, all right. Next question. A counterforce brace is used in which of the following condition? This typical is named brace for tennis elbow. Okay. So counterforce brace is used for tennis elbow. Okay. Okay. Next question. Guys, without this topic or questions from this topic, an orthopedic questions itself cannot be there. Right from the time when I gave my entrance exams to you give, and maybe the next generation gives also, this question is going to come. All of them somehow are very fond of this wrist fractures. So let's discuss overall view regarding all the wrist fractures. You know, they have asked like what is this deformity, that deformity. So somehow they want to find something else which has not been asked till now, and they test you guys on that. Okay. So let's have an overall look of this. Okay, because the discussion will be incomplete if you don't go through the wrist fractures. Even though this is very common, but every year questions are coming from this. I don't want you guys to miss out on that. Okay. An old lady slipped and fell at home. She was diagnosed with a Colles fracture. Now see, she is managed with a POP cast. What is the current sequence? Till now they would be asking what is the deformity, what are the characteristics of the deformity. Now they want to know how are you going to put the traction cast. This is going to be done by the postgraduate or an orthopedic consultant. But they want to test you that level for you guys in the NEET PG questions. Okay, so the next year they may even ask how many layers of POP you're going to keep for a Colles fracture. Okay, be prepared for that. All right, so the answer for this is traction, palmar flexion, ulnar deviation, and POP. Okay, now let's discuss about the other fractures around the wrist, where I'll explain each and every one of them. Okay. So around the wrist, I want you guys to differentiate between if it's an extra-articular injury or an articular injury. Okay, that is the first thing. If any question comes, I want you guys, if they give a picture, please look at that. Extra-articular means if the joint surface is outside, I mean the fracture is below the joint or involving the joint. Okay, if it is extra-articular, all right, then there is two possibilities. It could be a Colles fracture or a Smith fracture. In Colles fracture, the fragment is always, so this could be the dorsal and the dorsal and the volar. Okay, the fracture fragment is always dorsally displaced. Okay, it has dorsal tilt or shift and lateral tilt or shift with could be impaction or supination. If it's a Smith, it is going to be reverse. There's going to be a volar tilt, medial tilt, and impaction or supination can be there. So what is the sequence of fixation? Since it has gone dorsal, we'll have to give a palmar flexion. So it has gone dorsal. So you give a palmar flexion to reduce the deformity. Okay. So you're going to give a traction, loosen the fragments, give a palmar flexion, ulnar deviation, and then put a POP. Whereas for Smith fracture, you're going to do a traction. To the fragment is already volar. So you're going to give a dorsal flexion and ulnar deviation and fix it. Okay, guys. See, till now they were asking the deformity. Now they have gone to the question of how do you fix it. So with this knowledge only, we'll have to apply the fixation, but you should know about it. All right. So the most common malunion, what will happen? It will lead to dinner fork deformity in Colles, in garden spade deformity in Smith fracture. If it is an articular fracture, okay, articular is the radius articulates with the lunate bone. That is called as radiocapitular articulation. If that subluxates along with the intraarticular fracture, it is called as what do you call Barton's fracture. Okay, articular fracture plus the radiocarpal subluxation. This also can be volar Barton or dorsal Barton. If it is an articular fracture, eyes closed, you cannot treat it with a POP. You will have to fix it with a plate because all articular fractures have the chance to go for secondary arthritis. So you'll have to fix it and give an absolute stability for all articular fractures. Okay, you have to give a plating. Okay. So other named fractures, all right, other named fractures around the upper limb. Guys, one thing I want to put forth is there are numerous mnemonics going around. Okay, in Google, if you type, you will encounter numerous mnemonics. But honestly, tell me to remember the mnemonics, how many of you have made their own mnemonics? I found it to be a huge task, okay, to remember the various mnemonics because already in subjects like medicine, pathology, there are going to be so many mnemonics floating around. And for a short subject like orthopedics, where you will have to score all the points correctly, I don't think it is beneficial to remember all the mnemonics, okay. So even this named fractures, there is a reason why that name had given. If you are following it in that way, you will remember it better, okay. I suggest that. For example, let's see the chauffeur's fractures. Okay, who are chauffeurs? In those days, chauffeurs means drivers. Those days, driving when they started an engine, it is like how they start an auto engine now. They have to bend down and lift this. So, because of the recoiling effect of the ignition system, they get injured in the radial styloid. Okay, so that is why the name as chauffeur's fracture came in. Okay, similarly, other name fractures also, I'll try to give as many real life examples as possible so that it remains in your head. Okay, apart from this few name fractures, if you read it once or twice, it's going to be there. Don't rely on mnemonics for orthopedics, my humble request. Okay, so Schoffer's fracture is a radial styloid fracture. SX loprosity is a radial head fracture along with the DRUJ. Nightstick fracture, when you're defending in the night, you're going out for a walking, someone is trying to hit you, you're going to defend or block it with your elbow and the injury is going to happen here. What is the bone that is exposed? That's the ulnar bone. So the injury is an ulnar fracture. Okay, self-defense injury or ulnar. Or Monteggia and Galeazzi. Monteggia is, remember, M for up. Okay, so it is proximal third ulnar with the radial head dislocation. Galeazzi is distal third radius along with a DRUJ. If it is going to have a radial head plus a DRUJ, you name it as an SX loprosity fracture. Few named fractures around the upper limb. Okay. So, moving forward, a 65-year-old woman presents after a fall on an outstretched hand X-ray showing dorsally displaced fracture of the distal radius. So, what is this? Colles. And a dorsal angulation. What is the most appropriate initial management? We all know. Initial management is going to be close reduction and below elbow casting, POP fixation. Okay. All right. Look at this question. A 44-year-old woman presents with wrist pain after falling on her flexed hand. Shows a fracture of the distal radius. Now, what is this fracture, guys? This is an extra-articular fracture. The articular surface is maintained. Okay. So, this is an extra-articular fracture with the fragment is volar. So, this is a Smith's fracture. So, Smith and volar displacement. This is volar, this is dorsal. The fracture is coming volar base. Okay. So, the answer is Smith's fracture with an volar displacement. All right. A 35-year-old woman presents with elbow pain and swelling after falling while running. X-ray shows the following. What is the X-ray showing? Ulna is gone. Radiohumeral joint is gone. So, this is proximal third ulna with radial head dislocation. What is this? Montagia. Oh, yum. Yum is upwards, proximal. This is an example for Montagia type of injury. All right. Let's look at the next question. Okay. A 39-year-old male presents with long-standing right-sided wrist pain. He has failed conservative measures including prolonged immobilization. His radiographs or MRI are shown. Which of the following is an accepted treatment option? The X-ray almost looks normal, but in the MRI, you can appreciate this is the scaphoid bone, don't get confused. This is the lunate bone. In lunate bone, one part is going for necrosis. This is nothing but AVN of lunate. The other name for this is Qbanks disease. This is associated with a trauma, very insignificant trauma can lead to this, where there is increased ulnar variance. What you have to understand regarding this variance term is, usually radius is higher, ulnar is shorter. So, negative ulnar variance only is normal, but when ulnar becomes more negative, it goes more down because of any injury to the TFCC or lunate, it causes increase in negative ulnar variance. In that case, what happens is this radius will start to put more pressure on the lunate bone. Okay. So, thereby shutting off its blood supply, leading to avascular necrosis of the lunate, also known as the Qbanks disease. Okay. So, the treatment options would be to either do a radial wedge osteotomy to release the pressure, or proximal row carpectomy, wrist fusion, or total wrist replacement as the last treatment. Okay. So, the answer for this question is we have to treat the radial bone. Okay. So, ulnar shortening osteotomy not going to happen, TFCC not going to work, lunate chondroplasty debridement not going to work. So, the answer is the radius core decompression is the answer for Qbanks disease. Okay. All right. Important hand injuries. You have the scaphoid fractures. This is the most common carpal bone fracture. This is the most common missed fracture of the hand, and most common type is waist injury. Here only one thing that is very important which keeps coming is the blood supply. See, blood supply is pretty tricky, guys. Here the blood supply comes from distal to proximal. Okay. So, if there is a cut injury, the distal fragment will survive, the proximal will not survive. Okay. The blood supply comes from distal to proximal. So, the distal will survive, proximal will not survive. So, proximal undergoes avascular necrosis. Okay. So, non-union and then proceed to avascular necrosis. Okay. The scapholunate injury, a very important entrance point of your question because it has a name sign called as Terry Thomas sign. It is named after a comedian who has an increased gap between his teeth. Okay, increased gap of more than 3 to 4 mm we called as Terry Thomas sign for scapholunate type of injury. I'll show you a normal wrist X-ray. Okay, where you will be able to appreciate if there's any gap. So look at this. The gap between the scaphoid and lunate is very small. If the gap is increased by more than 3 to 4 mm, you call it as a Terry Thomas sign. Alright. Okay. Look at this question. A 30-year-old man presents with pain in his wrist after falling onto an outstretched hand. He has tenderness in the anatomical snuff box. X-ray is inconclusive. What is the next step in the management? Anatomical snuff box. What is the bone there in anatomical snuff box? Is the scaphoid bone. I told you this is the most common missed injury. So what you can do is you can take a repeat X-ray or in the option if they are given as CT, that would be the best answer. For these options, the answer would be to take a repeat X-ray in 10 to 14 days. MRI can show you AVN, but AVN will take time. So, to see the fracture, you need a CT. So, CT is the best option. If CT is not given, you can choose repeat X-ray in 10 to 14 days, right? Next question. A 35-year-old mechanic presents with a wrist pain and swelling after a high energy fall. X-ray showing this. What is X-ray showing? The radius is here. The carpal bone you see. So normally how the radius should be, it will look like a boat. This is the lunate bone, the radius bone. Here the lunate has become like this. That means lunate has undergone dislocation. So the answer for this is perilunate dislocation. Okay. Alright. Let's look at the next question. A 25-year-old boxer presents with pain and swelling at the base of the thumb after punching a wall. X-ray shows this type of fracture. So what is the treatment? Always remember guys, there are two types of fractures at the base of the first metacarpal. That is Bennett's and Rolando. Bennett's means fracture plus dislocation, but it is a simple fracture. Whereas if it is comminuted, it is Rolando type of injury. So this is a fracture, simple fracture with a subluxation is there. So this is an example for a Bennett's fracture dislocation, right? The next question. What classical finding is characteristic of involvement of the nutatory ligament in Dupuytren's disease? Guys, this thing we have to know to solve. Okay, this when is the web space involved, because questions keep coming from this. This is a relatively difficult question, so I've tried to make it as simple as possible. Pay attention guys. The Dupuytren's contracture occurs more in the female than in the male and affects mostly the ring finger. What happens is the palmar neurosis gets fibrosed because of various reasons. Okay, so what will happen is if it's fibrosis, eventually this will go for strictures like this. So at what point, if it's affected, leading to stricture of what structure becomes an important MCQ question. Pay attention. If it is a pre-tendinous cord, okay, usually MCP is involved. If it is a nutatory ligament, it will be the web space contracture. The spiral cord of palmar aponeurosis affected, that leads to DIP, PIP joint contracture. If it's a lateral cord, that leads to DIP contracture. If the same Dupuytren's occurs in the foot, it is known as a Lederhorst disease. If it occurs in the penis, we term it as a Peyronie's disease. So this has been repeated several times. Okay, they want to test you, challenge you. So this could be a very good question. Okay, so please go through this in the module. Right. A 54-year-old man notices that his right hand has developed a contracture, where the ring and the little fingers are gradually bending towards the palm, making it difficult for him to fully extend. He has a history of diabetes and heavy alcohol. There is a palpable thickening of the palmar fascia. This should be there to differentiate from ulnar clawing. Thickening of palmar fascia means Dupuytren's. Okay. So what is the surgical intervention? You will have to, the fascia has become thickened, right? Palmar aponeurosis fascia. So you have to release that fascia. That is termed as fasciectomy. Fasciectomy is the surgery of choice. Next common finger or hand related questions are trigger fingers. This is nothing but synovitis of the A1 pulley, which is most commonly affected. Most common finger is the ring finger. Most common tendon is the FTP. And decurvance is tenosynovitis of the first extensor compartment. The tendons affected are abductor pollicis longus and extensor pollicis brevis. The important test is the Finkelstein's test. What do you do in a Finkelstein's test is keep the thumb inside and make a fist and make a forceful ulnar deviation. You will have stretching of the tendons here, and if it is inflamed, it will lead to severe pain. So that is characteristic of decurvance tenosynovitis. Okay. Decurvance tenosynovitis involves tendon sheath of which two muscles? Abductor pollicis longus and extensor pollicis brevis is the answer for this question. Okay. And Which of the following tests is the most commonly used to diagnose deeper veins? It is the Finkelstein's test. Okay. Next question. A 24-year-old downhill skier crashes while spreading powder in the Italian Alps, injuring his ulnar aspect of the thumb. See guys, the skier thumb injury is only thing is skier's thumb, okay, or goalkeeper's thumb, gamekeeper's thumb. Where the thumb gets injured ulnar ways. The answer is ulnar collateral ligament. We know this, very simple. But now to make it tougher, even ulnar collateral ligament, like how we saw for the ulnar collateral ligament in the elbow, there's the lateral ulnar collateral ligament and medial ulnar collateral ligament. Here also ulnar collateral ligament, there is two structures, okay. The proper UCL and accessory. What we have to know is the laxicity, okay. If the laxicity is present only in flexion, okay, that means extension is still be there. So that means it is a proper one, okay, because accessory is maintaining the extension. If both are gone, you will have laxicity in both flexion and extension. So here in the question, they have said that examination relieves MCP laxicity only in flexion, not in extension. That means accessory is still there. So UCL and accessory, no. So this is not the answer. Only the UCL is torn of the proximal phalanx. Okay, remember that is the next level question which I am expecting from the INI-CET, since I have already tested you guys with the gamekeepers or the skier's thumb UCL. So UCL is attached to the proximal phalanx. There are two parts, proper and accessory. Proper means only flexion will go. Accessory will take care of the extension. If both laxicity is present both in flexion and extension, that means both proper and accessory are affected. Okay. All right, guys. Next, let's discuss about the lower limbs. Okay. First question. A 25-year-old male presents in the trauma bay after a motorcycle accident. The figure A shows the imaging obtained in the trauma bay. He is initially hemodynamically unstable, but responds to 2 liters of normal saline, 2 units of packed cells, and application of pelvic binder. He is taken to the CT scanner where a bleed is found. Okay, superior gluteal artery. What is the most appropriate next step? What is this type of open book injury which is notorious to cause hemodynamic instability? Okay, because vessels will get injured. So they're asking what is the most appropriate next step in the management. Okay, just look at the options. Taken to the angiographic suite, taken to the operating room for exploratory laparotomy, taken to the operative room for XFIX, taken to the operative room for exploratory laparotomy and XFIX. Here, what the clue is, there is a certified interventional radiologist is there. See, this interventional radiologist, what they can do is, if the bleed is present, to passing a stent, they can arrest that particular bleed. Since the patient is hemodynamically unstable and only stabilized after giving blood, we have to address that first. So, the answer for this question would be take to the angiographic suite. That would be the best answer for this question. Okay, guys? All right. Okay. Look at this question. A 28-year-old male presents after a fall from height of 15 feet. Okay. He complains of severe pelvic pain and instability to bear weight. On examination, he is hemodynamically unstable. A fast scan shows free fluid in the abdomen. X-ray shows a vertical shear. What is the most likely complication? So what they are asking is, a fast scan is there which is showing a bleeding in the abdomen and also a pelvic vertical shear injury. So the answer is the most common complication with a pelvic injury with an intraperitoneal bleed is hypovolemic shock due to retroperitoneal hemorrhage. Okay, pelvis injury 50% mortality rate. Let's discuss few points about the pelvis injuries. Okay, it is a high velocity injury, greater than 50% mortality for open type. Okay, 50% of mortality is there. Most common cause of mortality is because of hemorrhage, and the most common type associated with, if you follow the tiles, the Young Burgess classification, this is the APC, all right, in an APC, and also you'll have to remember the vertical shear, that also causes huge morbidity, all right. But for the question purpose, always stick APC type 3 is the mostly associated with hemodynamic instability. Other injuries are, it could be associated with ortho if you take only ortho. It could be the chest injury followed by long bones followed by spinal. Other system which is most commonly around the pelvis, the urogenital system, and then the head injury. Okay. See guys, you all may think or feel that going through the classifications would be very important, but trust me, till now, just identification of the fracture type based on the classification for pelvis and acetabulum injuries have not been tested. Okay, why? Because they are all olden day classification. The current classification with the evidence of CT, we use something called as AO classification. So need not break your head trying to remember these very difficult classifications. Max to the max, you remember this Gustlow-Anderson classification and the Schatzker classification for proximal tibia. Other things, I don't think it is essential because it is not being followed anymore these days. But still, for historical relevance sake, just look at the classification types. Okay. Pelvic injury usually classified into either tile classification or Young-Burgess classification. In tile, they have classified as based on the ring, the internal ring stability. Okay, it is either A, that means the ring is stable. B means the ring is stable vertically but not anteroposterior. In type C, it is both vertical and rotationally unstable. So B1 is a famous question of open book type. So they may sometimes ask you, open book types falls under which category? So it under tile classification type B. Okay. If you take as Young-Burgess, this classification was based on the direction of the force. Okay. So anteroposterior compression means the force is coming from the anteroposterior. So initially you will have a pubic diastasis and then the lateral structures will go and then the posterior structures will go. So in this APC type 3 is like complete crushing of the pelvis leading to massive hemorrhage. Okay. So hemodynamically unstable, most common causes APC type 3. The lateral compression is like you come from one side and go to the other side. So windswept comes under the lateral compression. Next is the vertical compression where one pelvis holds together and the other moves forward. Most classically it will involve the SI joint disruption. Okay. Yeah. So the treatment becomes, if it is a stable injury, only for type 1 we do conservative, rest everything we would do a open reduction internal fixation. If it is an unstable, always guys control the bleeding. At the emergency, you can put a pelvic binder at the level of GT, not at the level of umbilicus, at the level of GT, and then you can manage by using an X-fix or an angioplasty can be done to find out the cause of the bleeding and then to arrest that. All right. Yes. The next question. What is the spur sign on which view it is best seen? Okay. For here, let me talk about the acetabulum, the important concepts about acetabulum injuries which you guys should know, and then I will explain this, because blindly explaining this question will not be enough or sufficient for you guys to grasp the topic as a whole. Okay. So acetabular injuries are also high velocity injuries. They are associated with more of mortality. In this, the lower limb injuries are more, followed by the sciatic nerve and then the spine. Okay, there it was chest is more than the spine. Here it is lower limb injuries more than the spine. Okay, classification is given by the famous Letournel and Judet. He, in those days, just based on the X-ray, they had to classify. That's why they classified the simple types as elementary, all the permutation combination, the other one as an associated injuries. Okay. What are the simple? It could be the walls. How many walls we have in the acetabulum? One is the anterior wall, other one is the posterior wall. So anterior wall, posterior wall. The walls always hang around the building, right? So they need a column support. So the wall is associated with the anterior wall or an anterior column, posterior wall or a posterior column, or the transverse. These are the basic types. If any combinations of them occurs, they put it as an associated injury. All right. Let's look at the elementary fracture. See, if only this is the anterior and this is the posterior, if only the acetabular cup is affected, you call it as the wall fracture. Whereas the cup is resting on the bones of ilium ischium. Okay. If the entire thing is gone, you call it as an anterior column fracture. Okay, or as discussed, the isolated posterior wall fracture, which has the classical gullwing appearance. The gullwing appearance stands for posterior wall fracture, or it can involve the posterior column fractures or the typical transverse fracture. Okay. In X-ray, what are all the things that we can pick up from a acetabulum is, see, there should be an acetabular fossa. In that, you will have the anterior wall and the posterior wall and the important lines. Okay. So, iliopectineal line and the ilioischial line. Okay. So, the iliopectineal line is for the anterior column. Okay, see, this is the iliopectineal, the red line. Follow with me. It starts from the ilium and goes to the pubis. So, that is the anterior column. If it starts from the ilium and goes towards the ischium, it forms a posterior column. Okay, and in the normal structure itself, you will be having, when the posterior column or the ilioischial line meets with the anterior wall, you will have the development of the teardrop. So, teardrop is a normal finding. When you don't find the teardrop, that's when you signify a fracture. Okay, teardrop, remember guys, it's a normal. What are the name things that can come usually from an acetabular fracture? The teardrop can come. Gullwing means posterior wall fracture. Other one important means the spur sign. See guys, those days only based on X-rays they had to do everything. So just with one AP lateral view they couldn't fully find out where the fracture was. So they started taking an oblique views. Okay, those are called as judate views or obturator and iliac views. Okay. So see, these are the oblique views where you will be able to see the obturator foramen much better or the iliac wing much better. Okay. So those are called as obturator or iliac views. Okay. In obturator and iliac views only you will have this spur sign. Okay. Spur sign means column fracture. So spur sign is seen in an oblique view with an intact ilia. Okay. So for spur sign should be present, you should have it in the obturator oblique view with an intact ilia. Only then will you be able to find out the spur sign. The spur sign is an significant for a fracture of the posterior column injuries. Okay. Or typically seen as bicolumn fractures also. Similar to pelvis injuries, for acetabular injuries also, stable ones less than 2 mm disturbances, we use a conservative. For more than 2 mm, we have to operate. The famous named approaches are the posterior ones are the Kocher-Langenbach approach, anterior ones are the alioinguinal or the Stoppa's approach. May come as 1 marks, they may test you, but usually not. Okay, don't worry. All right. Let's come to the next interesting features of the lower limb injuries. All right. Okay. So follow with me for this question. A 35-year-old female presents to the trauma bay following a motor vehicle collision. She has a GCS of 15, hemodynamically stable, and complains of right hip pain. Okay. On examining, her right lower extremity is flexed, abducted, and externally rotated. Any attempts passive range of movements of pain is painful. What is the initial evaluation? What is the diagnosis? See guys, when it comes to hip, all of us know about posterior hip dislocation. Yes, posterior only is most common, but the next most common is the anterior ones. Okay, how do we find out is posterior is the most common in that the attitude will be flexion, adduction and internal rotation with shortening, and here vascular sign of Narath is positive. Anterior dislocation is flexion, abduction and external rotation with lengthening. Okay, and vascular sign of Narath is negative. In anterior dislocation also there are two types, superior type and inferior type. Superior type is the pubic type, inferior is the obturator type. Okay. So the answer for this question is anterior hip dislocation. Among the anterior hip dislocation, it is not going superiorly, it is coming inferiorly. So inferior one is anterior obturator hip dislocation. That's how the next level of questions will be formed. All right. Let's look at this question. A 35-year-old male presents to the emergency department after a high-speed motor vehicle accident. He complains of severe pain in his right hip and is unable to move his leg. On examination, leg is shortened, internally rotated and abducted. We know this is posterior dislocation. Which of the following is the next best step? Doctors, all I want you guys to remember is all dislocations are emergency. So the immediate next step is immediate close reduction of the dislocation of under sedation. If you are not able to do immediate reduction, you'll have to put them in the OT and take them for an open reduction. All right. So all dislocations are emergency in orthopedics. So the immediate step will always, you will have to focus on reducing the dislocated joints. Okay. Next question. A 70-year-old woman trips and on the grass while playing golf and sustains a displaced neck of femur fracture. What is the optimal treatment? The answer for this is THR. I will end the controversy for you guys now. Okay, when to do a hemi, when to do a total hip. This has been a controversy from the time I gave my exams till now. Okay, today we are finishing it once and for all. Okay, so what you have to understand is basically regarding proximal femur fractures, you have to divide them as either intracapsular or extracapsular. Extracapsular trochanteric, where shortening is more than 1 centimeter. They are neck of femur fracture with a shortening less than 1 centimeter. Since the capsule is holding them, it will not allow it to move proximally. Okay, so that's why all are externally rotated only. The foot will be externally rotated, but the externally rotated foot will not touch the couch. If it is touching the couch, then it is an extracapsular injury. If it is not touching the couch, it is an intracapsular neck of femur injury. Okay, and neck of femur, since in the intracapsular, high chance of AVN. Okay. So what is the management of neck of femur, which they keep asking again and again and disturbing you guys? Okay, see. For less than 65 years, okay, look at the duration. If the duration is less than 3 weeks, you can decide to fix them with a CC screw. If the duration is more than 3 weeks, tell him about the chances for AVN and then do CC screw but with a vascular graft. Okay. If it is above 65, you need not look for the duration of injury. Rather, you should ask for the mobility. If the patient has high mobility, you have to use THR. If he wants a low mobility, use a hemiarthroplasty. In this question, what I told you guys is he is playing golf. A golfer needs mobility. When a golfer playing person requires high mobility, you do a THR, total hip arthroplasty or total hip replacement. That is what is being done here. Okay. All right. A 45-year-old male underwent surgery for a subtrochanteric femur fracture with intramedullary nailing. Okay. 1 month later, he complains of persistent pain in the thigh and an inability to bear weight after 1 month. X-ray reveals non-union of implant failure. Which of the following is the most common? Actually, should be a change in the question. It cannot be 1 month. Okay, it has to be at least 9 months to term it as non-union. Okay, what is the most common causes? What is inadequate fixation of the fracture? That means what will happen is the implant could have broken. They would have weight borne much earlier. Okay. So that is the answer for this question. Inadequate fixation or implant breaking. So you'll have to revise the implant and fix it properly this time. Okay. Look at this question. After undergoing ORIF for the femoral shaft fracture, the patient begins rehabilitation program. What is the primary goal of physiotherapy? The primary goal of physiotherapy is always and always movements and muscle growth. Okay. So the movement and muscle growth is the primary purpose of physiotherapy. All right. So prevent joint stiffness and muscle atrophy. So coming free, we progress from pelvis to acetabulum to proximal femur to femur shaft. Now let us look at the lower down injuries. Okay. Around the knee, I want you guys to remember two things which are being tested very often. Okay. One is the OCD, the other one is the OST. OCD is osteochondritis dissecans, means one particular part of the bone gets necrosed and slips off. That leads to loose bodies in the knee. Okay, most common cause of loose body is idiopathic OCDs. Okay, and the treatment would be arthroscopic removal. The other one is the Osgood-Schlatter disease. That means apophysitis of the patellar tendon attachment, okay, with the tibial tuberosity. Characteristically, it will be causing theater sign. What is theater sign is when you are getting up from prolonged sitting, when there is a sudden extension of the patellar tendon leads to severe pain. Okay, the treatment can be conservative or you can treat it with a surgery, right? See, other things around the patella, around the knee joint, I would like to discuss is the patellar fracture. If it is a simple like olecranon, you do a tension band wiring. If it is a comminuted, you do an INICET clutch. For proximal tibia fracture, I asked you guys to remember the classification, that is a Suchker classification. For distal tibia, also known as the pylon fracture, you will have to scan, span, and then fix it for all severely comminuted proximal tibia and distal tibia. Okay. Look at this question. A 40-year-old male presents to the emergency department after a fall directing onto his knee. He is unable to extend his knee, and X-ray reveals a olecranon fracture, patellar fracture. Okay, so like how we discussed in patellar fracture, olecranon fracture, for patellar fracture also you can do a TBW, or if it is comminuted, you have to do an INICET clutch. This is not comminuted, a simple fracture pattern, so you'll have to do a surgical fixation with tension band wiring. Look at this question. An 18-year-old male presents with ongoing knee pain that limits his ability to participate in athletics. He was diagnosed with Osgood-Schlatter disease at the age of 18, has symptoms since the type of at that time despite rest and use of NSAIDs. What is true regarding surgical treatment? Okay, for such recurrent Osgood-Schlatter disease, we tend to go for a surgery. So, what is the feature about surgery is what they are asking. Surgery for Osgood-Schlatter is never indicated. No. False. Prednisolone injection should be admitted prior to surgery. No, not required. Oscal excision and tuberculoplasty will improve systems, but return to sport is unlikely. If the person is not going back to sport, what is the purpose of doing surgery? Alright. So, what is true is Oscal excision and tuberculoplasty will improve symptoms, and also the return to sport is likely. So, that is the answer for this question. Okay. Coming to foot and ankle, regarding ankle, remember this bimalleolar is Potts fracture, trimalleolar is Cotton's fracture. The classification for ankle injury is given by Long-Hansen classification, where depending on the types of forces acting, he has given various fracture classifications. Okay. Calcaneum fractures, also known as Lower's fractures, where calcaneum and vertebral fractures occur. Why Lower's fractures? Is because most common type of suicide is jumping from a top of a building. So when they do that, both calcaneum and spine gets injured. The X-ray, we always have to look at the bolus angle only. The treatment would be operative if there is a bolus angle decrease. Okay. And the main problem for treatment will always be a skin necrosis. Okay. All right. Let's look at this fracture. A 23-year-old female is brought to the emergency department after being involved in a motor vehicle collision. She is found to have an isolated close injury to the right lower extremity. Radiographs are taken. What is the second most complication? See, what is the fracture type here? This is the talus fracture, right? So, the most common classification of talus injury is non-union. The second most common is avian. So, the answer for this question would be osteonecrosis. Please correct it in my notes. Okay. This talus fracture is also known as an aviate fracture. Okay. All right. A 25-year-old basketball player twists his ankle during a game. He presents with swelling, bruising, and tenderness. Which is most likely? Most common non-bony injury around ankle is sprain. In sprain, the most common ligament is anterior talofibular ligament. But here, both anterior talofibular and calcaneofibular is given. Hence, the answer for this question would be both. Okay. Okay. Then what is Lisfranc injury? Is nothing but a tarsometatarsal junctional injuries. It could be bony or tendinous injuries. Bony, you will see a flex sign where the part of a bone is coming out like a chip, or the tendinous injuries, you will appreciate the first metatarsal and second metatarsal gap will increase. Okay. Gap between the first and second metatarsal. If it's a bony, it will lead to flexing. Okay. and the other named fracture is the Jones fracture, is the 5th metatarsal base fracture. Okay. Look at this question. Figure A is the weight-bearing radiographs of an active 34-year-old male who injured his right foot 1 year ago, okay, when he tipped off the skateboard. Which of the following factors would lead you to consider treating him with primary midfoot arthrodesis? Okay, so they're going to fuse it. Why? So look at classically at this example, you will have an increased space between the two bones and also a bone here. So this is an example for bony Lisfranc. So that is why they are considering that to do a arthrodesis. Okay. So primary ligamentous injury and a delay in treatment. So the answer is primary ligament injury and delay has been treated for 1 year. So delay has been for 1 year. Okay. Yes. We'll come back in a short 5-minute break. Thank you. Hi guys, welcome back. Let's discuss about the topic infection. Okay. So, in older adults, which bones of the body are most likely to become infected when organisms causing osteomyelitis spread through the bloodstream? Here, few important topics in infection which you guys should know is like how it is common among children and adults. The answer for this question is spine. Let's discuss them one by one. Okay. The important one-liners regarding infection or just factual concepts which you guys should know is the most common age by which infection can occur is children and old age. Both are immunologically compromised. The most common site is always metaphysis. Why? Because that's the hairpin loop arrangement present. The most common route of spread is always hematogenous, more important than the direct spread. Okay. The most common organism overall is Staph aureus. The most common organism in case of sickle cell affected patient becomes Salmonella. The most common organism for IV users is Pseudomonas. The most common for animal bite is Pasteurella. Most common in case of human bite is Eikenella. The most common for prolonged parenteral users is fungal infections. And location wise for most common in children is the ends of the long bones or femur, most common. And for adults it is vertebrae. Okay, these are important factual things which we should know about infection. Okay, there's not much concepts behind this. So now let's come to the concept part or the pathology part, pathophysiology part, which I am so interested in teaching you guys rather than learning about the one-liners. Okay, if you know this, whatever question that is going to come from infection, you will not at all miss it out. Okay, just pay close attention to me. Okay, see, infection of the bone and the medullary cavity is termed as osteomyelitis, whereas infection of the spine is called as spondylodiscitis. Okay, so infection of the bone and medullary cavity is called as osteomyelitis. So how can it be once an infection comes? Let's say it is there for the initial 4 weeks. So that we term it as an acute. What happens if infection is anywhere else in your body? What will be the reaction? You will have swelling, all the inflammatory signs around it, fever, rubor, tumor, choler, loss of function, right? So similarly, you're going to get a swelling and fever and all that. So similarly in the bone also, what's going to happen? So the swelling is going to be present inside the bone. Okay, that is called as an abscess formation. And you're going to get fever or reaction outside. So that is in the periosteum, you're going to get a reaction called as periosteal reaction. These two are only important in the acute phases. Okay, abscess for more than 24 hours, then periosteal reaction in 7 to 10 days. Okay, when this acute infection progresses to chronic, at that time we miss to treat them and it goes for more than 4 weeks. What happens is, you see there is an abscess there. What is an abscess? It is a collection of organisms. And what will be the nutrient status of that place? The organisms are rapidly destroying that. So that will become like a dead space. Okay. So that dead space is called as the sequestrum. Okay. So this periosteal reaction is continuing to be present. Okay. When this periosteal reaction is present on a chronic duration, it is going to lead to reactive newborn formation or involucrum. Okay. Now in the X-ray or the MRI, if they give and ask you to identify, you will never get confused what is the sequestrum and what is the involucrum. Sequestrum can only be in the medullary cavity in the middle, and involucrum can only be over the periosteum and not in the middle. Okay. So that will form the involucrum. Now, what is the next stage is what will happen is the sequestrum, since the organisms they continue to grow, they become powerful, they break the involucrum. That breakage is called as cloaca. When this cloaca breaks the skin, this leads to signs. Okay. This is the systematic flowchart for an acute to chronic osteomyelitis. If most of the topics you are able to follow a systematic pattern like this, you will not miss any points. Okay. So, the earliest indicator for investigation for infection to find out less than 24 hours is MRI. In X-ray, earliest you find 7 to 10 days periosteal reaction, but the investigation of choice always remains as biopsy. The treatment would be, you'll have to remove everything: sinus extraction, sequestrum removal, saucerization, And to prevent that gap, you put a cement or use the mascale technique. Okay. Since if you remove this large chunk, there's going to be a gap in the bone. So that is going to be unstable. So you stabilize this, put a bone cement till everything heals, and then remove the cement and put a bone graft. This is called as mascale technique. Right. Alright, next question. Ring sequestrum is seen in, we all know it's a pinhole external fixator. A child presents with fever and discharging pus from the right leg for 3 months. Following is a radiograph of the child. Identify the label structure. They are labeling on the periosteum. So what is the only structure on the periosteum? It is the involucrum. See, that's how simple it is. Right? Now, let's look at this question. Figures A to C are the radiographs and CT images from a 33-year-old diabetic man who was treated with intramedullary nailing following an open tibial shaft fracture. He continues to have pain in the leg. Despite the course of IV antibiotics, his laboratory markers remain elevated. What is depicted by arrow? Okay. So, definitely this part is infected. There are so many changes occurring. Implant is present. And they've given an arrow. This comes often in INI-CET. Okay. The arrow is pointing towards inside. Okay. Not on the periosteum. Not on the periosteum. So, this is an example for sequestrum. Okay. So, the types of sequestrum, like one question, how would that come is a ring sequestrum. Few other types of sequestrum is coralliform sequestrum occurs in Perthes, annular or ring sequestrum in the Pintrax, tubular sequestrum in acute osteomyelitis, in feathery sequestrum could be in TB, black sequestrum in fungus, and ivory sequestrum for syphilis. Okay. Look at this question, guys. Identify this condition. Okay, there is a lytic lesion. All right, lytic lesion. But what doubts you can have in such a question comes, sir, can't it be a lytic tumor? Usually, guys, when they give a tumor, they'll give the age of the child. Okay, some other clues will be given. Okay, this with the age and this only we can identify the tumor. So I'll discuss about the algorithm of tumors in the upcoming. So now just a lytic lesion if isolated they're given. Look at the option also. So they're termed in terms of like chondromyxoid fibroma, hemangioma, Brody's abscess, and osteoid. So for all these tumors, you need the age to identify, not just with the picture. Okay. So without that to identify, mostly with the elimination itself, you can say Brody's abscess. But what I want you guys to understand is in Brody's abscess, you will have the abscess, okay, of the acute osteomyelitis, but there is no periosteal, reaction. So that is called as subacute infection or Brody's abscess. Okay. So special types of infection, the first one is the Brody's abscess. This is a subacute form. Most common is in the proximal tibia. Where pus is there, it leads to abscess, no periosteal reaction. Whereas in Gary's sclerosing osteomyelitis, it is a chronic type where only periosteal reaction is there and no pus. So that occurs mostly in mandible more than tibia. Okay, two special types, remember guys, Brody's abscess and Gary's sclerosing osteomyelitis. Brody's abscess occurs in subacute phase, only abscess, no periosteal reaction. In Gary's sclerosing osteomyelitis is chronic, no pus, only periosteal reaction. That's how easily you can remember that. Okay. All right. Next question. A 33-year-old motorcyclist is involved in a motor vehicle accident and sustained a grade 3 open fracture of his tibia that is treated surgically. Over the next 35 years, he undergoes multiple rebioprin for a persisting draining wound. That is multiple episodes of osteomyelitis he has had. Okay. And this has led to a fungating mass. Okay. This is something like a cancer. So, what is the type of cancer? This is a squamous cell cancer, and that is the most common type of cancer that can come from such type of an ulcer. I'll give you one more question from this. What is the type of this ulcer is known as Marjolin's ulcer? Okay, Marjolin's ulcer will lead to a squamous cell carcinoma. Okay. From osteomyelitis, what is the next stage? From the bone, what is close to the bone? The joints. When infection via the hematogenous route or the direct route affects the joints, it's called as septic arthritis. And this is the true surgical emergency in ortho. You cannot delay it because the joints once destroyed, the cartilage never comes back again. So this always remains a true surgical emergency. The most common organism once again is the Staph aureus. The most common joints in adult it is knee, but in children it is hip. Whenever there is infection around the joint always tends to be in a position of ease. If in your mind, if you try to remember this degree, flexion degree, extension degree, you will forget. Just imagine the point of ease of your own limbs, okay? If your knee, which is the most relaxed portion of the knee, when you slightly bent it. So that is the point of ease for the knee, 5 to 30 degree of flexion. In hip, nighttime, how do you sleep? You keep a pillow in between and you snuggle up and sleep. That is the point of ease. So that is flexion, abduction, external rotation. Okay. So the point of ease is where the joints are relatively stress free. That's how in infection also the joints will be placed. Okay. The body adapts like that. Okay. So as discussed before, investigation, earlier you can do an X-ray or the blood investigation, but always confirmation is by, you can take a sample from the joint, arthrotomy, you take a sample and send for a sample, and a biopsy, that is the confirmatory. The treatment would be always emergency arthrotomy. This is a true surgical emergency for orthopedics. Okay. The complications would be if the joints are destroyed, they're going to cause bony fusion. That's how the joint is, the body will heal itself and the joint's function is gone. It will be like a single bone. You will not have any movements in the joint. Okay. Yes. Next question. Tom Smith arthritis destroys what? These are characteristic pediatric arthritis. So Tom Smith arthritis is going to destroy the femoral capital epiphysis. Among pediatric arthritis, two things are important, guys. Okay. One is the Tom Smith arthritis and the other one is the transient synovitis. Okay. In less than 1 year old child, you're going to get the Tom Smith arthritis where chondrolysis of femoral head occurs and the head gets destroyed. Okay. But in older children, you will have something called as transient synovitis. Here it could be both acute or chronic. In that case, you'll have to look at the signs called as the Kocher's criteria as to when you can treat it with antibiotics or when you want to surgically intervene. Okay, this Kocher's criteria is very important for pediatrics, guys. Remember, the criteria involves non-weight bearing, raised temperature about 38.5, ESR above 40, and WBC about 12K. When more than 2, okay, greater than or equal to 4 is present, you'll have to do an arthrotomy, or less than 2, you're going to do with an observation. Okay, when these signs, because you see children will not cooperate for an MRI, right? If you ask them to lay still, it's going to be a very tough task. Rather, with a clinical, since it's an emergency, based on a clinical sign and blood investigation, we'll have to decide for surgery. Okay, less than 2, you can wait and watch with antibiotics. More than or equal to 2, that is like from 3, you will have to do an arthrotomy. Okay. All right, let's look at the next question. All of the following are considered the cardinal signs of flexor tenosynovitis. Okay, the flexor tenosynovitis, the signs are given by, like how I mentioned, the Kocher's criteria is the Canavel sign. Don't forget this. Okay, the Canavel sign includes 4 features, which is tenderness along the flexor sheath, fusiform swelling of the finger, pain on passive extension of the finger, and flexed attitude of the fingers. These 4 things form the Canavel sign. The answer for this question, except, is not on flexion, it's always on extension. Okay. The other infections that can occur around is the phelon, pulp space infection, paronychia is the nail bed infection around the nail. Okay. The always treatment is INT. Right. Next question. Surgery, including biopsy, is indicated in TB spine in all except, okay. Next, we are going to discuss about TB spine or TB spondylodiscitis or pot spine. Okay. Now, let's discuss this and come back and solve this question. All right. In TB infection, what we have to know is The most common site overall remains pulmonary. Okay. From in musculoskeletal, the most common is the spine, then the hip, then the knee. In spine, what is common is the dorsal-lumbar junctional is most common, then dorsal and only then lumbar comes. Okay. In TB spine, what are the features is port spine will be there, then the granulation tissue is going to be produced that will cause neurological deficits leading to POTS paraplegia. Okay, that is about TB spine as a nutshell. In TB shoulder, it is called as caricica, or TB dactylitis, you are going to have a spina ventosa. These are all the named TB infections of the musculoskeletal system which can come as individual questions. Okay. Now TB spine. Here, paradiscal or end plates are more commonly involved because high blood supply. Okay, so end plates will first get involved, then only central of the vertebrae, then the anterior and then the posterior. But anterior is most common in children. One exception which you should know. Okay. Earlier symptom is pain, low back pain or mid back pain. Sign is spasm. Gait will be cautious gait. In X-ray, what is the earliest is the end plate destruction, and last only you will have the disc space reduction. Okay. So end plates, high blood supply, TB affects them first. So that is going to be the first sign, and disc space reduction is going to be the last one. Okay. Deformity, since the end plates are destroyed and the vertebrae are also destroyed, you're going to have a kyphotic deformity. In the kyphosis, only one vertebrae is involved, you call it as a knuckle. If 2 to 3, you call it as a gibbous. More than 3, you call it as a kyphosis. The gold standard always remains biopsy. Okay. The paraplegia is due to the granulation tissue, and then you are going to have a complete element type of lesion. So you do a biopsy. If there is a decompression to be done, you do a surgical decompression and start ATT for 18 months. That will be the treatment protocol for TB spondylodiscitis. In that case, the questions, let's come back to the questions. Okay. Surgery, including biopsy, is indicated in TB spine in all except evolving cauda equina. It's an emergency surgery. Cold abscess without neurological. See, they are not given any neurological compromise. In that case, surgery is not indicated. Let's look at the other options also. Drug resistance TB, what other options we have? No medicine, so only surgery can be done. Doubtful diagnosis, always take a biopsy. So the answer for this question is B. Look at this question. A 35-year-old male presents with chronic back pain, weight loss, night sweats and neurological deficits. For this itself, you know it is TB. MRI shows vertebral collapse and abscess in the thoracic spine. What is the most likely diagnosis? There is the gibbous formation. So gibbous most commonly occurs in port spine or spine tuberculosis. Okay. Alright. Let's go to the next topic. Okay. A 72-year-old man came with complaints of unilateral knee pain. Okay. X-ray examination showed reduced joint space. Okay. The pathological findings shown are, leave out the histology. Okay. In the histology, what you have to know is, so these clear structures, okay, the pink structures are the bone and the blue structures are the cartilage. Here the cartilages are only affected more than this. What is a disease of cartilage called? Nothing but osteoarthritis. Alright, osteoarthritis is a disease of the cartilage of the knee. Most common is the knee joint. Okay. Okay. The degenerative arthritis type, most common one is osteoarthritis. This is a disease of the cartilage. The most common joints affected are knee more than the hip joint. Okay. The X-ray will show decreased medial joint space, which is the earliest one to occur. There is osteophyte formation, bone cysts and subchondral bone sclerosis, not anywhere. Subchondral bone sclerosis is very important. Okay. And this hand, okay, this I personally don't agree to, because arthritis, you'll have pain and deformity everywhere. Very hard to pick up with these hand signs. But this has been there since the time orthopedic textbooks have been printed. So the questions are coming from this. So for that point of view, you please know, in osteoarthritis, if the DIP can be involved, PIP is involved, but MCP is rare. Never it is given that does not happen. It is only rare. So DIP involvement is called as Herberden's notes. PIP is called as the Boucard's notes, but MCP involvement is quite rare. Okay. The treatment for degenerative arthritis is, as always, first is non-surgical, then only you move to surgical. Non-surgical, you try all the NSAIDs and weight loss therapy. In surgical, it is going to be TKR or THR. Okay, clear guys? Clear for degenerative arthritis. Let's go into the next type of arthritis. Okay, osteoarthritis. A woman presents with pain, swelling and redness of the knee, joint and hand. Okay. There were associated complaints of morning stiffness with problems in squatting. The swelling spread the DIP joint, spared the GIP joint. The image of the patient's hand is shown below. What is the diagnosis? See guys, the difference between a degenerative arthritis and a inflammatory arthritis is pain after work. Here, pain at rest. Example is morning stiffness. Why? Why? Everyone says this, but why? How do you remember? That is important. Here, it is the cartilage that is gone. But here, it is not the cartilage. It is the inflammatory molecules that are deposited in the joint. So, the knee joint, let's say example of a knee joint. See, any joint is a closed space. Okay. When the cartilage is gone, frequent movements, that's when the pain starts because of injury of the subchondral bone. Pain fibers get stimulated and you develop pain. That is an example for degenerative arthritis. Whereas in rheumatoid arthritis or inflammatory arthropathy, here inside you will have deposition of the inflammatory molecules. That is why there is pain at rest. The joint is fully stiff. Okay, the fully stuffed joint is there because of the inflammatory molecules deposition. So on movement, slowly the inflammatory molecules will release off from the joint and they will have relief of pain. So that is the reason for having pain at rest for inflammatory arthropathy. The classical example for inflammatory arthropathy is rheumatoid arthritis and degenerative arthropathy is osteoarthritis. Now I think you will not miss which will have rest pain and which will have pain after work. Okay, all right. So the answer for this question is morning stiffness is there, pain, swelling and redness. That means inflammation is there and morning stiffness. The answer for this question is rheumatoid arthritis. Okay. And to explain about this classical deformity. These are the deformities of RA. And this classical type is the swan neck deformity. Okay. We will discuss about them one by one. Right. All right. Okay. Rheumatoid arthritis. This is a disease of the synovitis leading to inflammation. Cartilage disease was osteoarthritis, right? Females are affected more than the males. The joints affected are predominantly the small joints of the hand. Only DIP is sparing. MCP, wrist, PIP is goes. On the major joints would be the knee and the hip. And axial is very rare, but even if it occurs, it will be C1, C2 subluxation. Okay. Pathology is because of the synovitis, you're going to have inflammation. That is called as the pannus. Okay. And that is going to get deposited into the joint leading to fibrous ankylosing. Okay. So, the diagnosis is given by the Euler's criteria and blood investigation. What we have to remember is the difference between RA factor and ANT-CCP. RA factor is IgA against IgG, but it is not confirmatory. It helps in prognosis. The confirmatory is anti-CCP, which is more specific. Okay, don't make mistake in this, guys. RA factor is for prognosis. The confirmatory is given by the anti-CCP. The criteria name is Euler criteria. Small joint involvement is compulsory to diagnose, to make the diagnosis of rheumatoid arthritis. Okay. So deformities, let's understand it very easily. From the hand, we'll go to the other joints. From the hand, the most common one is the swan neck deformity. Swan neck means PIP is extended and DIP is flexed. If the PIP is flexed and DIP is extended, opposite is the bottonios deformity. If only DIP is flexed, it is the mallet's finger, or there can also be Z deformity of the hand. At wrist, what happens is, from the ulna, we'll have to move towards the C. Dorsal subluxation of the ulnar hand. Okay. So, ulnar portion in the wrist becomes dorsal. Okay. Ulnar. It will go like this. To compensate for that, the carpo-metacarpal joints. Okay. The carpal and the metacarpal joints will compensate in this direction. The radiocarpal joint is going in the ulnar direction. So, this will come in radial. Okay, that's when you will have the Z deformity. Remember the letter Z, that's how the deformity occurs in rheumatoid arthritis. So, dorsal subluxation of the ulnar head, radial deviation of the CMC, and again ulnar deviation of MCP. That is the classical of rheumatoid hand or Z deformity. In knee, this is a very tricky question, but more for the NEET exams rather than for the INICET. I don't think they'll be asking this question for the INI-CET. But no, in knee, the valgus is more common than varus, which is more common than windswept. But windswept most commonly occurs in rheumatoid in adults. Okay. Valgus becomes more common than varus. The third one only is windswept. For windswept, rheumatoid is the most common cause. Okay. In foot, you will have the hammer's toe or the hallux valgus. In skin, you will have the rheumatoid nodules. Okay. So the treatment becomes the medicine drug of choice remains till date is methotrexate. Okay. The first line DMRs you also know HCQ, sulfasalazine and all that. The second line becomes the biologicals based on which questions comes for you guys. Okay. The TNF alpha inhibitors are infliximab and adalimumab. Interleukin 1 antagonist as the anakinra. Anti-CD20 is the rituximab. Okay, rituximab, right? The surgery wise, if it doesn't settle, we'll have to do a synovectomy and TKR or a THR for rheumatoid arthritis, just like for a degenerative arthritis. Okay, I hope the difference is clear between the inflammatory arthropathy and the degenerative arthropathy. Okay, moving forward to the questions. A 60-year-old man with dull inflammatory back pain for the past 10 months. He has difficulty in sitting and standing up. X-ray shows fixed SA joints and syndesmophytes and perivertebral classification. The classical feature of ankylosing spondylitis. Okay. Most specific for the diagnosis of ankylosing spondylitis is HLA-B27. A 45-year-old male with back pain for 20 years presents with complaints of neck stiffness. What is the diagnosis? You look at this. What is this? Posteriorly, it is called as bamboo spine. And that is typical of ankylosing spondylitis. Okay. Alright. A 28-year-old male with a history of ankylosing spondylitis presents with heel pain. Examination reveals tenderness over the Achilles tendon. This is an example for insertional tendinitis or called as enthesitis. Okay, classical. All these four questions I have framed from the classical signs of ankylosing spondylitis. Bamboo spine, HLA-B27, SI joint and enthesitis. If these four structures are there, it can't be anything else in the world other than SI joint, other than ankylosing spondylitis. Okay. Few words about the seronegative spondyloarthropathy. The groups, okay, all arthropathy which are RA negative are termed as seronegative spondyloarthropathy. What all it includes is seronegative. It includes the ankylosing spondylitis, psoriatic arthropathy, IBD, inflammatory arthropathy, all come under seronegative arthropathy. For ankylosing spondylitis, the classical features are female more than the male, HLA-B27 positive, and uveitis. In the joint, SI joint is must or most characteristic. Okay, then only spine involvement, even bamboo spine. Okay, the pathogenesis is enthesopathy, all the tendinous attachments. So there will be weakness of there leading to enthesitis. The clinical features would be the Faber's test or the Schober's test. X-ray will show the bamboo sign or the shiny corner sign. Diagnosis is using the ASA criteria. Treatment is NSAIDs and steroids and some extent DMARDs. Okay. Look at this question. A 47-year-old male complains of long-standing pain involving the right index, middle and ring fingers. Okay, only the fingers. A clinical imaging is shown in figure A and figure B is radiograph. What is this typical? It has been so eroded that you have a cup, you have a pencil in cup appearance. This is nothing but psoriatic arthropathy. Pencil in cup appearance is nothing but psoriatic arthropathy. Okay. A 50-year-old male history of psoriasis presents with joint pain and stiffness in the fingers. Examination revealed dactylitis. X-ray shows the following. What is the characteristic feature is what the question is. So I'll just remove this so that you can appreciate it clearly. Just if you focus on these joints, you will see that this is spreading out. Okay, and this is going in. This is also early stages of penicillin cup. Okay, this penicillin cup are a feature of psoriatic arthropathy. Along with this, you will also have periarticular osteopenias. Hard to pick it up from the just with the X-rays, but classical feature, if it involves only the small joints of the hand and no other joints, it is 99.99% psoriatic arthropathy. Okay. Okay. Psoriatic arthropathy is an erosive type of inflammatory arthritis diagnosed by the Casper criteria. Most common is the DIP joint. You will have associated nail changes as well. X-ray, you can have penicillin cup appearance, or if the entire finger bones get destroyed, you will have the arthritis mutilans. The treatment is using methotrexate and steroids for management. That's how we are going to manage a case of psoriatic arthropathy. Okay. Okay, next question. A middle-aged man presents with acute onset right knee effusion with pain. He reports that such episodes are recurrent. X-ray shows punctured periarticular lesions, a thing but gout. Okay, let's discuss few things about the crystalline arthropathy. In crystalline arthropathy, you would have three things. Okay, gout, CPPD, and Milwaukee. Okay, gout is nothing but monosodium urate crystal deposition. In pseudo gout, it is calcium pyrophosphate deposition, and Milwaukee shoulder, you're going to have calcium hydroxyapatite in shoulder. Okay, this is characterized by increased uric acid. Pseudo gout occurs with hypoparathyroidism. Okay, the characteristic joint involvement is the first MTP, next only is the knee joint. In pseudo gout only, predominantly first itself knee joint occurs. Then in carry shoulder is always the shoulder. Okay, Milwaukee shoulder is always the shoulder. Okay, so diagnosis by the negative bispheringian crystals. Here this is the positive bispheringian crystals. Treatment first line includes NSAIDs for all. The second line for gout, you can use xanthooxidase inhibitors like aropurinol, febuxostat, rasburicase. All uricosurics like probenecid, or which is also known as colchicine. So the first line always remains as NSAIDs, NSAIDs, NSAIDs. For acute pain, you will always have to treat them with NSAIDs. Okay. Next question. Which of the following bleeding disorders is caused by an X-linked recessive mutation? Hemophilic arthropathy. Okay, hemophilic arthropathy. About hemophilic arthropathy in related to orthopedics. Okay, this is related to orthopedics. Okay, so both A and B, factor A deficiency and factor level deficiency, are typical examples for hemophilic arthropathy. Okay. So, other classical features of hemophilic arthropathy are the factor 8 and the 11, factor 8 and 11, not 9, factor 8 and 9, right, yes, not the factor 11, it is factor 8 and 9, okay. Recurrent bleeding will occur into the joint, and the joints more commonly affected are the knee and the elbow. The classical X-ray finding is the squared patella and widened intercondylar notch. This is not present any other condition. Okay, squared patella and wider intercondylar notch. The treatment is hemophilia management. Okay, look at this question. A 70-year-old woman with type 2 diabetes presents with an erythematous, swollen and warm left foot as depicted in figure A. There is features of inflammation is there. A radiograph is depicted. Radiograph is complete mayhem. I call it as a mayhem. Okay. Complete mismanagement of all the joints. Such thing with diabetes history is only one thing in the world, Charcot's or neuropathic joint. When nothing you are able to differentiate, okay, in at least in other joints you can see some osteophytes, subchondral sclerosis. Here nothing, you can't even see the joint. In that case, the diagnosis becomes Charcot's or neuropathic joint. The answer for this question is Charcot's arthropathy, erythema decreases after elevation. Alright. About the neuropathic joint, which is also known as Charcot's joint, associated with diabetes mellitus, syphilis and leprosy. What are the 6 characteristic Ds are? Destruction of the bony structures, decreased density of the bones, there will be bone debris, it will be disorganized, dislocations will be there and distension. The only treatment option is fusion for these patients. Okay. Yes. Let's go to the next question. A 60-year-old patient with limping gait and left hip pain. What is the likely diagnosis? Here, if you pay close attention, the joint surface and joint space is maintained. You can't say arthritis, but if you are able to locate this, then you are brilliant. These are called as cysts. In which condition will there be cyst formation early stage of the joint? Only one thing called avascular necrosis. But avascular necrosis is basically a diagnosis of MRI, right? MRI only you can confirm it and not with the X-ray. Few points regarding avascular necrosis, okay? Avascular necrosis literally means decaying bone or dying bone. The classification could be traumatic or non-traumatic. Traumatic is, we have already seen, most common head of the femur, more proximal pore of scaphoid, body of talus. In non-traumatic, it is the most common cause is idiopathic, associated with smoking, okay, and long-term steroid use. Okay, the other associated conditions are Chandler's disease, sickle cell anemia, Perthes, steroid and alcohol. Okay. So here, how do you classify it is based on the MRI. Okay, come to the clinical features first. Female are more affected than males. 50% occurs bilaterally. Characteristic features is painful limp with antalgic gait. In examination, you will find that decreased internal rotation and abduction and sectoral sign is positive. The gold standard always is MRI, where you will be able to form the Ficat and Arlett stage. In bone scan, you are going to get the donut sign. See, in the MRI, you will be forming the cysts. Everything will be clearly given in the MRI, right? More than the X-ray. So the stages based on X-ray and MRI. Repeat again, MRI becomes significant for sickle cell, for avascular necrosis. That is, in stage 1, X-ray is usually normal. Okay, in 2A is when you start developing sclerosis. For 1 and 2A, the treatment remains only bisphosphonates. Okay, in 2B, when the X-ray shows crescents forming, you will have to do a core decompression. Along with the core decompression, you can give a bone marrow injection or vascularized fibrous graft can be present. In 3, when there is a complete collapse of the head, there is no other go but to do an osteotomy. In stage 4, when you have a head plus acetabulum involvement, the only option remains as total hip replacement surgery. Okay. Other questions relating to avascular necrosis. Which part of the scaphoid is most susceptible? We have already seen it as a proximal third due to blood supply comes from proximal to distal. Okay, blood supply comes from distal to proximal. Alright. So this is the distal part, this is the proximal. So that is why distal will survive, proximal will not survive. Okay. Assertion and reason. Okay. Assertion is proximal pole of scaphoid is the most common bone to undergo avascular necrosis. Reason, blood supply is retrograde from distal to protrograde. Yes. Both assertion and reasoning are independently true and reason is the correct explanation for assertion. The answer is A. Okay guys, we'll have a small 5 minutes break and come back. Okay. Welcome back, guys. Now we're going to discuss about the metabolic bone disease. Here, I want you guys to pay attention to this one metabolism. Okay, one metabolism which I'm going to explain to you guys, and with that, you can solve all the questions from metabolic bone disease. Never try to by heart the tabular column. Increase, 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 this condition. Decrease, increase, increase, decrease, this condition. Don't go by that vendor. Try to understand the reason behind why calcium and phosphate are increasing or alkaline phosphatase is increasing. Then you will not be going wrong. Pay attention to this one metabolism. Okay. Everything revolves around parathyroid gland or parathyroid hormone. Okay. Follow with me. I'll explain this metabolism or my diagram better so that you can easily recollect them. Okay. So this parathyroid hormone has a large amount of influence on the serum calcium and phosphate levels. Okay, all right. So what happens is that it has action primarily at three areas. Okay, first is the bone, second kidney, and third on the small intestines. First, let's focus on the bone. In bone, this parathyroid hormone initially acts on the osteoblasts, and then via rank ligand it goes to osteoclast. Okay, we know osteoclast is bone remodeling or bone resorption. It will absorb the calcium and phosphate from the bone and put it into the blood. So eventually what will happen? There will be increased serum calcium and increased serum phosphate. So parathyroid hormone causes bone resorption, but it cannot directly act on the osteoclast. Via the osteoblast, it acts via the rank L ligand. But in kidney, it activates via vitamin D3. What happens is it stimulates the reabsorption of calcium and increases the excretion of phosphate. And in the intestines, it increases calcium absorption. So ultimately, the net effect of PTH in the body is increased calcium, that is serum calcium, and decreased serum phosphate. This many people fail to understand. They just look at one particular metabolism on the bone and think it causes rise of both calcium and phosphorus. No. Ultimate by action on all the three areas, it causes rise in serum calcium and decrease in serum phosphate. Okay. Now the other cofactor is the vitamin D3. Vitamin D3 is a very good and very important structure. Its only job is to increase serum calcium and serum phosphate, mainly in the intestines. It's rare for the bone, but mainly in the intestines, it increases the calcium and phosphorus absorption. So, increase in serum calcium and serum phosphate. Okay, so this is a very good guide, very simple to understand. Okay, but parathyroid hormone has action at three levels, and the ultimate is increase serum calcium and decrease serum phosphate. Now let's come to the the this thing table. Okay, now let me cover up this table for you guys. Okay, I want you guys to enter this. Okay, oh sorry, let's take up a darker color like it's not good. It's okay, never mind. All right, so focus on this condition of primary hyperparathyroidism. So don't look at the box just now. Okay, just listen to me. Okay, primary hyperparathyroidism example is an adenovirus. What is happening? The parathyroid hormone is increased. Okay, the primary is from the parathyroid gland. The parathyroid hormone is increased. What did we see the results? There will be increased serum calcium and decreased serum phosphate. Is that there? But the primary is the parathyroid hormone. That increases. Whenever parathyroid hormone increases, ALP will increase. Okay, they both are friends. So this increase. As a result of this only, calcium increases and phosphate decreases. But In secondary hyperparathyroidism, the problem is at the kidney. What did we see the function of kidney as? It reabsorbs calcium and excretes phosphate. When the kidney is gone, the calcium also goes in the urine and phosphate cannot be excreted, so it remains. So what will happen is, there will be normal or decreased calcium and phosphate increases. This will be the primary pathology, and this in turn by negative feedback activates the parathyroid hormone. Okay, eventually leading to this and increase alkaline phosphatase. If you understand where the primary pathology is, understanding the negative feedback becomes much easier. In primary hyperparathyroidism, the primary is the parathyroid gland. Here the primary is the calcium and phosphate itself due to the kidney. Okay. In tertiary, there is complete deregulation. Everything is elevated. So you can never go wrong in tertiary hyperparathyroidism. The only other two things are the rickets and hypophosphatemia. Rickets means what? Vitamin D deficiency. What did we see the role of vitamin D? It increases both. If rickets, when the vitamin D is low in both, it causes decrease of both calcium and phosphate. So as a result, there is a mild increase in the PTH and ALP. In hypophosphatemic rickets or in independent rickets, vitamin D independent rickets, as the name implies, it is only hypophosphatemic. Only the phosphate is less, rest everything is normal. After reading through the mechanisms and when you apply this in my tabular column, I guarantee you're not going to miss out on anything. Okay, simply by hearting the tabular column will not register that in your mind, guys. So understand the metabolism. Even in the metabolism, most of the books, they talk only about the bone. They forget the important action on the kidney. Only if you understand that, you'll be able to apply that for the tabular column. All right. Now let's solve some good questions. Okay. First we solve the hypopara thyroidism. Okay. Now next important condition is the osteoporosis. Osteoporosis means quantitative decrease in the bone volume or mass. Quantitative decrease. Okay. The primary most common cause is senile. Next is the menopausal. Secondary is because of drugs. Among the drugs, most common is steroids. Okay. The most common symptom being back pain. The most common fracture is the spine fracture, followed by the neck of femur fracture, and then only the Colles fracture. Okay. The investigation of choice is the DEXA scan. Here we look into the T-score and not the Z-score. Z-score for same age, but we need to compare it for the younger age, right? So we look at the T-score. In T-score, -1 to -2.5 is penia, and less than -2.5 is porosis. Remember guys, osteoporosis is always quantitative. Okay. So the treatment will be, we'll have to decrease the bone resorption, increase bone formation. How do you decrease the bone resorption? Okay. The drug of choice for that first line of choice is the bisphosphonates. This affects osteoclast and inhibit bone resorption. But it has side effects like atypical fracture of the femur or osteonecrosis of jaw. Hence, the second line drug becomes the recombinant parathyroid hormone. Doctor, wait, you told me parathyroid hormone causes bone resorption by activating osteoclast, right? How can it be used to bone formation? Brilliant. Here you have to note down the point that the parathyroid hormone first acts on the osteoblasts, then rank ligand, and then goes on activating the osteoclasts. What happens is, when you give it in a short burst or pulse therapy, it leads to osteoblast activation. Only on chronic continuous usage, it causes bone resorption. Okay, so pulsed recombinant parathyroid hormone, commonly known as teriparatide, is the drug of choice for osteoporosis. Only contraindication is osteosarcoma, okay, and Paget's. Okay, now the future drug of choice is strontium, but not yet widely available in the market. Okay, this has both decreases bone resorption effect and also increases the bone formation, right? The surgical treatment, if fractures has occurred because of osteoporosis, you're going to do either a vertebraloplasty or a balloon kyphoplasty for a vertebral fracture, okay? Look at this question. A 65-year-old woman with a history of multiple vertebral fractures presents for evaluation. Bone density testing shows a T-score of -2.8. So this is osteoporosis. The patient is currently on calcium and vitamin D. What is the next best step? So they are asking the next best step. Okay, only calcium, vitamin D. So they initiate pharmacotherapy with bisphosphonates. Next to that will be recombinant parathyroid hormone. Okay. All right. Next condition. Okay, this condition, guys, Paget's or osteitis deformans. If picture based, the skull based, bone based questions are coming. Sadly, if you guys in the exam are stuck up, not able to remember, 99% go for Paget's, you will be at the right answer. Okay. This Paget's has so many X-ray findings. Okay. And the X-ray finding names are all different. Largely because it was not discovered by someone from India or our friends where they could have named it as Thomas sign or Raja sign. They were all foreigners who had the name for their own taste, and we end up remembering them. Okay. So I'm giving a clue 99%. If you're confused with any skull X-ray sign or bone spine X-ray sign, please go for Paget's. If in the option Paget's is given. Okay. Or the name signs I will teach you, but that is the shortcut. All right. So in Paget's, what is that is there is increased osteoclastic activity 20 times more than a normal, characterized by increased ALP. Okay. So stages of Paget's are lytic stage, blastic stage, as well as mixed stage. It will be there. Okay. So the genes is a XQS TM1 gene. This has come as a question, guys, in names. I am so sorry, you have to know it. Or the paramyxoma virus. Most commonly it occurs in the 5th decade, the most common bones being the pelvis and tibia. Clinically, it presents with pain and warmth. Okay. It is associated with, because of increased osteoclastic activity in the blastic phase, when it compresses the 8th nerve, it can cause deafness. When it compresses the optic nerve, it can cause blindness. Or when it causes a lot of calcification on the blood vessels, it can lead to high output congestive cardiac failure. All right. This much Paget's can do. All right. So many conditions are combined with Paget's, and each one can be tested. Deafness, blindness, CCF. So don't forget this. Now coming to the important X-ray identification. As I told before, if you are unsure, please select the answer as Paget's. All right. Look at this. Only one condition in the orthopedics, which I have predicted most commonly asked in the NEET and the INI-CET patterns, is in the pelvis. If you are seeing diffuse calcification or sclerosis like this, 100% it is Paget's in the blastic phase. Only other condition which can trouble you with the pelvis is there will be small dots like this. That is either chondroblastoma or chondrosarcoma of the pelvis. Okay. But 99% this will be Paget's. Then in the tibia, you are able to see multiple lesions like this. Or the medullary cavity has almost become like a blade of grass. This is called as a saber tibia. Okay. In the femur, if you are able to see a particular lytic region like a grass piece, it's called as a lytic blade of glass appearance. In tibia, it is the saber tibia. In femur, it is the blade of grass. In skull, if it is the lytic stage, it presents as cotton wool spots. In sclerotic phase, it presents as Tamo shatter sign. Okay, guys. In spine is a characteristic one, doesn't appear anywhere. It is the outer end plates become thickened. It's called as the picture frame or ivory vertebrae. Okay. The complications of Paget's is it can cause secondary osteosarcoma, and hence parathyroid hormone is contraindicated. If you see in 90% of metabolic bone disease, the drug of choice is parathyroid hormone or teriparatide, but not in patients, as the risk for secondary osteosarcoma is very, very high. Okay. All right. Next question. A 70-year-old man presents with bone pain and deformities. X-ray shows characteristic appearance and laboratory tests revealed elevated alkaline phosphatase levels. What is this? TAM-O shatter sign, and this is the picture frame vertebrae. The answer for this is Paget's, and the treatment choices definitely first one is bisphosphonates. Okay, remember parathyroid hormone is contraindicated. Okay. A child presents with difficulty in walking. The wrist radiograph is shown below. What is the diagnosis? Guys, this can be widening of metaphysis. Can only be present in rickets. Okay, cupping, fraying, widening, all these terminologies points towards rickets. Okay. Now look at few points about rickets. Rickets after skeletal maturity, we call it as an osteomalacia or multiple loser zones. Okay. Weak bone disease. You will have multiple loser zone in the bones. Before skeletal maturity, we call it as rickets. Rickets further classified as vitamin D dependent rickets or vitamin D independent rickets. Vitamin D dependent rickets are three types: nutritional, type 1 and type 2. In type 1, the enzyme required to process vitamin D is decreased. In type 2, the receptors are gone. So all these vitamin D dependent rickets, you will have decreased calcium and phosphate, because vitamin D's main role is to absorb them from the intestine. So both are decreased, characterized by increased PTH and ALP. In vitamin D independent, or also known as hypophosphatemic rickets, the only pathology is decreased phosphate, rest everything is normal. This is most commonly X-linked recessive, PEX gene and FGF23 mutation. Okay. So the characteristic X-ray features are cupping of metaphysis, widening of epiphysis, and white line of freckle in later stages. Cupping, fraying, widening can occur only in rickets. They'll give either knee joint X-ray or the wrist X-ray. The treatment regimen, named regimen is TOS regimen. This much if you know it's enough. The treatment is going to be vitamin D supplementation only. These things are not required. If you have time, go through it in the module. But the treatment name is can be asked as TOS regimen. Okay. So what is the genetic inheritance pattern of hypophosphatemic rickets? Is autosomal recessive pattern. The next question is, a 7-year-old male presents to the orthopedic clinic with leg pain that has been present for the past 6 months. The patient recently immigrated to the United States from Somalia. On physical exam, the patient appears malnourished. There is tenderness to palpation, and additionally gums have bluish hue and areas of hemorrhages. What is this? Bone pain in child with hemorrhages. Yes, vitamin C deficiency, scurvy. Okay, and the X-ray is typical of that. I will describe the X-ray to you guys. Okay, the answer for this is scurvy, which is characterized by widening of the zone of provisional calcification. Okay, what is scurvy? Vitamin C deficiency characterized by collagen maturation deficit. Okay, collagen formation deficit, osteogenesis imperfecta, where there is collagen maturation defect. All the lab values appear normal. Okay, now in X-ray, what all will you find is, in diaphysis you will have pencil thin cortex and subperiosteal hemorrhages. In metaphysis, you are going to have white line of Frenkel, Tremorfield zone and Pelton spur. The white line of freckle extending outside is called as a Pelton spur. You're going to have the white line of freckle is for the calcification that's going to occur, and the lytic area above that is the Tremorfield zone. In epiphysis, you'll have the Wimberger ring sign, where the epiphysis will become like a ring, right? The classical clinical features are bleeding gums, subperiosteal hemorrhages, and petechia. The treatment is going to be vitamin C supplementation. A 5-year-old child presents with symptoms of joint swelling and pain. The child's diet lacks fresh fruits. X-ray shows subperiosteal hemorrhages and metaphyseal abnormalities. What is the diagnosis? Subperiosteal hemorrhages and bone problem is only one thing, is vitamin C deficiency. How long would you expect in this child is because of bone problems, he'll have abnormal gait and difficulty in walking. Okay. Alright. Which of the following condition will cause intermittent breakings of long bones? Only one condition, osteogenesis imperfecta. Okay. So, other question. A 5-year-old child presents with limb deformity characterized by unusually short curved tibia and fibula. Okay, here if you can appreciate, it will be various stages of fracture healing. Such conditions characterized by only osteogenesis imperfecta. Okay. So, what is osteogenesis imperfecta? It is a brittle bone disease characterized by collagen A1 gene deficit, where collagen formation itself is deficit. There are two types, autosomal type AD, autosomal dominant and autosomal recessive. Autosomal dominant presents with recurrent fractures. The recessive type is a lethal. They will die with stillborn stage. Clinically, you will have the blue sclera, delayed dentition and multiple deformed bones. Okay, multiple deformed bones. Not just one or two, there will be multiple deforming of the bones. Alright guys, let's move on to the next topic. Okay, pay attention guys, very important topic, and it seems to be a very tough topic, but I'll make it very easier for you. One thing before heading towards this bone tumors, I want you guys to understand that it is not necessary for you to by heart or know all the tumors. Orthopedic oncology has become a separate branch in orthopedics. So, even me being a spine surgeon, if you ask me to name all the tumors of the spine, I will not be able to do it. And luckily for you guys also, it is not mandatory. What is required for you guys is correctly establish the diagnosis and know the treatment. Okay, that is what is ultimately important. Now, to know this, I know orthopedic oncology is the toughest chapter in orthopedics, and mostly we'll be avoiding it because you're going to get hardly one question. Why do you have to spend so much time trying to answer? But I have given a simplified algorithms in a systematic manner by which, if you know this, that one point will be the make or break mark in your INI-CET ranking. That one mark can change your fate. So, I'll make this as simple as possible, orthopedic oncology, with an algorithm based approach so that you don't lose mark in this chapter. Alright, so this is going to be the highlight of my discussion for you guys today. So please pay close attention. Right? First question. A 52-year-old female presents with metastatic breast carcinoma, presents with moderate left shoulder pain. Figure A through B are radiograph CT images. Examination reveals mild tenderness but no swelling around the proximal humerus. Examination is negative for other causes of shoulder pain. According to Mirrell scoring, what is the most appropriate next step in the management? See, why this is important is, like for other pathological fractures, okay, in tumor, if the pain is starting, pain occurs before the fracture, that means what? It is going to get fractured sometime. So when do we figure it out? How do we manage it? Do we put a POP on loan, or do we do the preemptive treatment? So that has to be decided. For that, the helping score is the Mirrell scoring system. This till now has not been tested in the INI-CET, but future can be tested because it is very easy to apply, right? So those who know this will be able to apply it correctly. Okay. To know this Mirror scoring, it is based on three categories. Okay, site, where it is there, the pain is present or not, the lesion size. Okay, so these are the, and the lesion type. Okay, so how they're giving the marking is 1, 2 and 3. Okay, for what all 1 mark is, if the site is upper limb, 1 mark. If the pain is a mild pain, if it is 1 mark. If it is a lesion is a blastic type, is again 1. And the size is less than 1/3, it is 1 mark is given. If 2 marks for lower limb, moderate pain, mixed type, and the size is from 1/3 to 2/3. And 3 marks are for peritrochanteric type, severe pain, lytic type, and greater than 2/3 in length. In the whole calculation, if it comes more than 8, better to do a prophylactic fixation. Okay. Let's see for this question. This question is what, upper limb or what, shoulder? So it is upper limb. So mark is 1. The next is pain. What type of pain? Moderate pain. So pain is, for pain category, you have to give 2. Next is lesion type, sclerotic or lytic. See, you can see a sclerotic lesion. So for sclerotic, again it is 1. And the size, I would say something 1/3 to 2/3. Say it is 2. So the total score is 6. So less than 8. For 6, what is the option? Radiation therapy. Mirror score is type 6. So why can't this come as a question, guys? This can come, and I'm sure it will come. Next. When performing an open biopsy of musculoskeletal neoplasm, which of the following principles does not apply? This question was asked in one of the INI-CET, but I feel there's a small mistake in this question, guys. Know the principles, and if the same question, I don't think is going to get repeated. This is a wrong question, they'll change it. Okay. So know the principles based on which you'll be able to answer it. Okay. Incision, it is always in line with the long axis. You cannot make a transverse or a Z-type incision and all for a tumor. It's always in line with the long axis. Tourniquet, yes, can be used. Dissection is, we have to minimize through the multiple muscular compartments. As simple as possible, we'll have to maintain the incision. Diagnosis is by the frozen section. And closure, what all you have to do, you have to acquire a hemostasis and layer tension-free closure. In closure, the drain can be used, but it should come out through a separate incision. It should along with the same incision. You should not make a separate incision, because that separate area will form a new track for the tumor to spread. So, take the incision along the same, take the drain along the same incision. Okay. So that is why in this question all seems correct. Okay. Dissection through intermuscular planes should be avoided. Yes, it should be avoided. Only the simple we have to keep. A tourniquet should be used. Yes, it should be used. The incision should be placed longitudinally and in line with the intended future excision. Yes. Excellent hemostasis should be maintained. All seem correct as per the principles. That's why I have a doubt in this question. I don't think the same question can get repeated. But based on the principle they have asked once, that means there's no stopping them from asking again. Each line in this will be a question, guys. Okay? Each line. The incision is going to be along the long axis. The tourniquet can be used. Dissection minimized through multiple planes. Diagnosis by frozen section. Closure, you're going to do hemostasis and layered closure. A drain can be used, but it will exit along the incision, not by a separate incision. Okay. All right. Now comes my favorite algorithm, right? Guys, there are so many tumors, guys, bone tumors. I have classically divided them in 3 categories. Okay. Sclerotic tumors, lytic ill-defined tumors, and lytic well-defined tumors. I want you guys to pick up 2 clues from the question. Any tumor based question, guys, this applies for any and every question. Age of the patient and X-ray is given, means whether it is a lytic lesion or blastic lesion. Sclerotic lesion means in the bone it will be radio opaque. Lytic lesion means in the bone it is going to be radio. So radio opaque, radio lucent, and the age. I want you to make sure of this only. With this, we'll solve the entire tumors. Seems simple, right? Let's see. Okay. In the X-ray, you are finding it is plastic or sclerotic type. That means radio opaque type. You apply the age. Less than 30 years and more than 30 years. Okay. More than 30 years, it could be either MUTS or multiple myeloma. This holds good for all. Okay. More than 30 years, the first thing to come to your mind is multiple myeloma or metastasis. Less than 30 years, there are only two sclerotic lesions. Okay. Only osteoid osteoma or osteosarcoma. How do you differentiate? Is based on this periosteal reaction. Nothing, it's very simple. Okay, a bone is there. Outside the bone is where you're going to have the periosteum. If the periosteum is lifted like this, or if the periosteum is coming off like this, these are all examples for aggressive periosteal reactions. The periosteum is like this. This is an example for benign periosteal reaction. So X-ray, you find out it's sclerotic, age less than 30. You look for the periosteum. Periosteum is aggressive or benign. If it is a benign, there is only one possible thing of osteoid osteoma. Very simple. If it is an aggressive periosteal reaction, only one possible of osteoid osteosarcoma. This can never change. This is as it is. Alright. Let's solve these questions and identify. Right. A 13-year-old male presents to your office with a painful, palpable prominence over the anterior leg that has been present for over a year. He tried rest and has completed a 6 weeks course of physical therapy without much benefit. NSAIDs do help alleviate the pain, but his pediatrician fears gastrointestinal side effects. So guys, what do we want? Age is 13. X-ray is what? It is a sclerotic type. Look at this. This is sclerosis. Inside is lytic. Inside is free. The outside is fully sclerotic. Okay, that's what you should note. Okay. So sclerotic less than 30 is two things. Osteoid osteoma or osteosarcoma. What do we have to see? Periosteal reaction. What is the periosteum? Periosteum is normal. Periosteum is normal. Periosteum is normal. So the 100% the option is osteoid osteoma. There goes our answer. You will never miss out on this. So what is the treatment of choice for osteoid osteoma? The current treatment of choice is magnet resonance guided high intensity focus ultrasound. Previously they said just NSAIDs and rest, but right now the treatment of choice is magnetic resonance guided high intensity focused ultrasound is the treatment of choice. Okay. So regarding osteoid osteoma, it is a benign type of tumor, 5 to 25 years of age, characterized by increased pain at night. Okay. Relieved with NSAIDs. The most common bone affected is the proximal femur, more than the tibia, more than the spine. X-ray, you will have the nidus formation. On the bone scan, you will have the double density. The treatment of choice is MR high intensity ultrasound. MR HIF. Okay. The next question, guys. Let's solve the same strategy. Okay. An 8-year-old patient presents with 3 months of increasing pain and swelling of the left knee. Okay. Radiographs and MRI are in figures A to C, with histology is also given. Lucky. Which of the following surgical techniques has been proven to have higher self-reported outcomes? Okay, same. Age is 8. You look at the X-ray. What is this, sclerotic or lytic, guys? This is the lesion. Definitely, I think this is not lytic. You're not seeing any lytic area. This is sclerotic. So sclerotic. So two types, osteoid osteoma or osteosarcoma. Look at the periosteum. In both these X-rays, you cannot make out the periosteum, but in lateral view, you are able to make out the periosteum. So periosteal reaction is aggressive. This is called as the Codman triangle. The periosteum is lifted off. This is nothing but osteosarcoma. So that's how simple it is. Orthopedic oncology. Okay. So the treatment of choice which has the best outcome is the Van Ness rotation plasty. For this it is a MRHIFU. For osteosarcoma it is the Van Ness rotation plasty. Okay. So about osteosarcoma, it has a biannual occurrence, that is primary is from 10 to 20 years, secondary is 40 to 60 years, most common progression is from the pages we already saw. It is a tumor location in the metaphysis, most common bone is the knee and most common radio resistant tumor. Okay, and it is also the most common radiation induced bone tumor. Okay. It has a chance of metastasis to the lungs. Types is the most common is what we saw intramedullary. The other could be the periosteal, parosteal. Periosteal and parosteal will be outside the periosteum, okay? And parosteal has the best prognosis because you can just remove it as a mass. And telangiectaxic, that will be similar to the aneurysmal bone cyst. We'll discuss it later. Don't confuse it, okay? So the most common is intramedullary type. So this is the periosteal reaction which I want to explain, okay? Just lifting of the periosteum itself is an aggressive type. This is the Codman triangle or such, you see, burst appearance. This is called as the sunburst appearance of periosteal reactions. All right, next question. What to be done next? There's a lesion, seems large, lytic one. So what is next? Always a bone biopsy. Without a biopsy, don't treat. That's all. As simple as that. You will be in medico legal soup. You will have to confirm it and only then you have to start your treatment. Okay. A 10-year-old male child presents with pain around the left knee joint. On X-ray, there is a lesion of the distal femur. Gross specimen tumor of the lower end of femur is shown below. What is the most common diagnosis? Less than 10-year-old, periosteum is also involved and it is a huge mass, distal region. Only one thing is osteosarcoma. Okay. Age, X-ray, periosteal reaction for sclerotic tumors. Okay. Don't forget that. Now we come to the next algorithm, that is for lytic tumors. Okay, I already told you what is lytic. In lytic, you need to know two things: ill defined and well defined. See, if a bone is there like this, if it's a clear cut lytic like this, sorry. If it is a clear cut lytic like this is well defined. Okay. If it is not clear like this, you don't know when it is transcending, but you know it is lytic only, but it is not clear. Okay. The zone is extending outside also. In that case, it is called as ill defined. Okay. This is very important. Okay. Now, an ill defined lesion, X-ray, lytic ill defined, and the age similar to sclerotic only. More than 30 is only multiple myeloma or metastasis. More than 30 is always malignant. Okay. In less than 30, you are going to have Ewing's or eosinophilic. Okay. Ewing's or eosinophilic. How do you differentiate this? Ewing's is monostotic. It is present only in one area of the bone. And eosinophilic is granuloma is polystotic. Okay. A lytic ill-defined bone tumor less than 30 occurring in solitary lesion is Ewing's. The multiple location less than 30, you can think of eosinophilic granuloma. Okay. All right. Let us solve this question. A 15-year-old boy presents with swelling in the upper diaphyseal part of tibia. Okay. The X-ray of the swelling shows a periosteal reaction. Yes. Okay. So what is this? Okay. They have mentioned the age as less than 30. X-ray shows periosteal. Okay. A histopathological image of the biopsy is given. Okay. Thank God they have given histopathology. It says positive for synaptophysin mycto. What is the diagnosis? Guys, even though periosteal reaction is there, we don't know without X-ray whether it is sclerotic or lytic. Okay, so don't fall for that. Now they have given a clue as histology. The small blue cells, multiple blue cells are only two things: multiple myeloma or Ewing's. In multiple myeloma, the cells will be like this. You will have two structures like eye cells, we'll call orphan eye cells. The other small round blue cells is 100% one and only Ewing sarcoma. Okay, we have narrowed down our diagnosis, and based on certain criteria, we are helping to solve the question. Okay, the answer is Ewing's. Or rather, what will happen if you are not able to narrow it down in your mind, like 12 to 20 tumors will be going on and on and on. You will be struggling to figure out the answer. Okay. Now, next question. A 10-year-old male presents with ongoing complaints of left thigh pain after falling during a football game. A clinical photo is seen in figure A. ESR's WBC is elevated. Okay. Now look at the X-ray. Less than 10 and X-ray. This is sclerotic or lytic. Okay. Don't get confused with osteoid osteoma. Why I have set up this question is to help you guys to understand the difference only. Okay. Here you see the sclerotic part is more than the lytic part. So it is more sclerotic. But rather if you see here, the lytic region is more than the sclerotic. So this is more of a lytic but ill-defined. The borders are not at all defined, right? So such cases, what did we say? Less than 20 lytic, this ill-defined lytic is only one place, it is like Ewing's. If it is more than one place, you can put as eosinophilic. One place is Ewing's. And also histology wise, multiple blue cells. The translocation is T1122 EWS FL1. Okay. Let's discuss a few things about Ewing's. Okay. Males are more common than the female. Most common tumor of the first decade, but mostly it occurs in the second decade. 5 to 20 years. Okay, most common in the femur and diaphysis. Clinically, this is also another clue. It mimics inflammation. That is, similarly, they'll give a history of trauma, raised ESR, WBC, and all. Okay, mimics inflammation. An X-ray, you'll have a lamellated onion peel appearance. Investigation of choice, as usual, is always biopsy, which will show small round blue cells. The genetics is T1122, and the treatment is, even though it is radiosensitive, treatment of choice is chemo plus or minus radio. Chemo, limb salvage plus or minus radio. Even though it is radiosensitive, we give chemo plus or minus limb salvage and then only radio. Okay. Now, this algorithm, the third and the most final algorithm, is slightly on the difficult phase compared to those two algorithms, but not very difficult, because here we are going to see about 7 tumors as a whole. There you saw 2 in sclerotic, that is osteoid and osteosarcoma, 2 in lytic ill-defined, which is Ewing sarcoma and eosinophilic granuloma. Here you are going to see totally 7. So slightly more things to see. Similar to the rest of the algorithms, age more than 30 itself means blindly go for either multiple myeloma or metastasis. Malignant ones, don't think of anything benign. Less than 30 years, let's see how this 7 can be solved. Here, lytic well defined, I want you guys to divide this into 2 categories. Okay. 2 categories, that is, how is the matrix? Free or granulation. What is matrix? See, bone is there, lytic tumor is there, but inside We know it is lytic, but what if we have dots like this? This is not sclerotic. This is some calcification is present in the matrix. Okay. You have to divide whether the matrix is free or granular. Matrix is free means we have three things: non-ossifying fibroma, unicameral bone cysts, or aneurysmal bone cysts. Okay. Here, we easy to differentiate is unicameral bone cyst only in diaphysis of humerus. Non-ossifying fibroma and aneurysmal bone cysts can occur in the metaphysis. Okay, but the difference is one will be eccentric and the other is central. Okay, now let's look at an example. See, unicameral bone cyst, lytic lesion, diaphysis. Aneurysmal bone cyst is metaphyseal, but it is central. Non-ossifying fibroma is metaphyseous but eccentric. See, with this, three diagnoses over. Three tumors are over. Metaphysis eccentric, metaphysis central, or diaphysis. Okay. Next three option is with granular matrices: enchondroma, osteochondroma, osteoblastoma. Okay. Enchondroma means they'll give only hand X-ray. Hand X-ray means only two things, guys: Brown's tumor or enchondroma. Enchondroma, you will have the typical picture of calcification. Okay. Osteochondroma, you are going to have this stalk-like appearance. Away from the bone, it will develop a stalk and grow. Like our stem comes out, our branch comes out. And chondroblastoma, you are going to have this chicken wing calcification. Okay. Chicken cage wire calcification. You are going to have this multiple calcification. Slightly more complicated than the sclerotic and lytic ill defined, but you will know. Okay, not very difficult. So see how we are going to differentiate this. If it is a lytic well defined, the matrix is clear. You have three options: unicameral bone cyst, which is going to occur in the diaphysis; non-ossifying fibroma, which is metaphysis but eccentric; aneurysmal bone cyst, metaphysis but central. If it is a matrix is filled with granulation or any calcification, if it's in the hand, it is enchondroma. Stalk-like appearance, it is coming like a branch, it is osteoblastoma. And chondroblastoma is will have the chicken wire calcification. Okay. Only one thing is left is the GCT. Giant cell tumor, you will never miss. It is metaphysis going to the epiphysis with expansion of the bone. The only tumor which doesn't destroy the bone cortex but expands the bone. That is example for giant cell tumor, right? Let's solve few questions and then go, okay? All right. A fallen fragment sign is characteristic of, even though they asked this, you'd say this. This is a child's X-ray. You can see from the X-ray itself. This is in the diaphysis, lytic lesion, and humerus. Only thing is unicameral bone cyst or simple bone cyst. So, simple bone cyst is the answer, and they have the fallen fragment leaf sign. Okay. So, unicameral bone cyst is unilateral, diaphysis, most common is humerus. X-ray will have the fallen leaf sign. Treatment is, if the fracture occurs, you will have to immobilize it. Recurrent fractures means you can do curettage and bootcamp. Okay. Aneurysmal bone cyst, you have less than 30 years of age, expansile and, sorry, it's not eccentric, it is a central lesion. The translocation is T16-17 or 22-13. Okay. Acute fracture, you don't only immobilize it. Only after the fracture has healed can you think of curettage and bone grafting. Since it is very aggressive, you can even put this phenol, liquid nitrogen to prevent the recurrence. This is used for GCT also. Okay. So in chordoma, you will have the physalliferous cells. Adamantinoma is multiple location in the tibia. Okay, few other clues, but hardly questions have come from that. Okay. A patient presented with multiple swelling in the hands and wrist. Finger X-ray is given below. What is the answer, guys? Multiple in the hand, only two things I said. Brown's tumor or enchondroma. So Brown's tumor is lytic like this, clear. Any calcification, it is nothing but enchondroma. So multiple is there. So the option is multiple enchondromatosis. Okay. So enchondroma is most common tumor of the hand and feet, but most common tumor of the hand, most common bone tumor of the hand and feet is enchondroma, but plain tumor of the hand is squamous cell carcinoma. Okay. Treatment is curettage and bone grafting. Here it is associated with two things, Olliers and Maffucci. Olliers is just multiple enchondromatosis. Maffucci is multiple enchondromatosis plus hemangiomas and lymphangioma. That is nothing but Maffucci syndrome, right? In osteochondroma or exostosis, it comes like a stalk and grows hollow. Okay. Most common benign bone tumor it is. It is sessile and pedunculated. The stalk is always away from the joint line. Okay. This can turn malignant. Okay. 1% turns malignant. For that, identification factor is the cap is 2 centimeter and heavy calcifications will be present. Okay. Here, if it is multiple hereditary exostosis, it's called as MHC or diaphyseal achalasia, which is autosomal dominant and characterized by EXT1, 2 genes. Okay. All right. Next question. About giant cell tumor, all are true except commonly presents in 20 and 40 years group. Yes, true. Matrix consists of proliferating mononuclear cells. Yes, true. Osteoclast giant cell constitutes a proliferating tumor. No. It is a benign tumor. Yes. See, only thing which has a ballooning feature where the cortex is not broken and has sobable appearance or crackling sound. It's nothing but giant cell tumor. Okay. The giant cell tumor, the tumor is not the giant cell but the mononuclear cell. Not the giant cell but the mononuclear cell. A 32-year-old female presents with swelling and pain in the right wrist. The symptoms have progressed over the past 6 months and she has noted a decreased range of motion. What is the best treatment option? What tumor it is? From metaphysis to epiphysis it goes expansile, ballooning, so GCT. So what is the best treatment option? I told you, you have to give curettage application of liquid nitrogen and polymethyl acrylate because they are aggressive. So this is useful for aneurysmal bone cyst and also GCTs. Okay. So about GCT is a benign one, aggressive one, 30 to 50 years after physis closure only. Epiphysis, knee and wrist, female more than male, you will have an eggshell crackling. In the metastatic variant, you can have a C-MYC and P53 mutation may be there. X-ray, you'll have this ballooning or the sobable appearances. Biopsy, you'll have the mononuclear cells, which are the tumor cells and not the giant cells. Okay. So lung metastasis is there. Most common DD is Brown's tumor. The treatment includes curettage and application of liquid nitrogen, but you can add denosumab, Rank L ligand inhibitor, to decrease the size and stabilize lesion and then proceed with the surgery. Since it is ballooning, you can add a Rank L ligand inhibitor, okay, denosumab, and then proceed with the surgery, right? Alright guys, we'll break for lunch. We'll come back and discuss the rest of the questions, okay? Hello everyone, welcome back for the post-lunch session. Now we'll discuss about the nerve injury chapter. Usually in the nerve injuries, we have used to questions coming from Seddon's classification. Now in the recent few exams, I have started to notice a trend where they ask questions from the Sunderland classification as well. Sunderland classification studying alone separately can cause some confusion among the students. Hence, what I have done, I have condensed both them together, not everything the same, but try to match it with appropriate sentence classification. Okay, let's just have a brief look at it and then go about solving the questions. Okay, so pay attention. Okay, so the first is going to be the sedans, followed by the Sunderlands, whether the myelin sheath is there or not, endoneuron is present or not, the EMG and the spikes. Okay. So why this endoneuron is important, what you have to understand is only if this is there, regeneration is possible. If endoneuron is absent, regeneration cannot happen. Okay. So let's go about that. So the first stage of Seddon's classification we all know is a neuropraxia. The classical example is Saturday night's palsy, where there's just a stretch of the nerve. So in Sunderland, they come under the category of 1. Here, the endoneuron is present, so there will be good regeneration chance. And so, since there is good regeneration potential, in EMG, there will not be any fibrillations. Alright. So, the spikes also will be present. Alright. Now, okay, it's a reversible type of injury. Now, if you look at the axonomesis, okay, because of the fracture or the dislocation of the nerve is actually compressed, they will come under Sunderland's 2 to 4. Here, in the categories 2 and 3, you may find the endoneuron, but in category 4, endoneuron is absent. So, wherever there is like endoneuron is absent, that is regeneration is doubtful, you will start having the fibrillations and positive spikes. So in the earlier stages of Sunderland, that is like 2 and something, you're not going to have fibrillations and spikes. But as and when the stage progresses like 3 and 4, you're going to start develop fibrillations and positive spikes. When that is present, the regeneration chance is negative. Alright. When neurometsis, whether direct cut injury to the nerve or Sunderland's type 5, okay, when the endoneuron is completely absent, you're going to have good fibrillations and positive spikes with negative regeneration is potential. Alright, this is very important. I've tried to combine them as much as possible to give you an edge in the exams. Right. So, most important structure for the nerve recovery as always is going to be the endoneuron. There is no change in that. The investigation of choices. See, nerve conduction velocity is the best modality, but the earliest should be the EMG. Okay. The prognosis criteria, just remember nerve is growing. Alright. So, N is for neuropraxia as the best prognosis. Early type of injury, radial nerve as the best. Okay, vascularity should be intact, end-to-end cut, and growing children. They have the best prognosis. The best prognosis among the nerve as discussed above is the radial nerve. The worst prognosis is lower limb sciatic nerve and upper limb is the ulnar nerve. Each one is a question. Alright guys? Okay. So first let's finish off the obstructive brachial plexus palsy. Here I would like to mention that many obstetricians didn't like the usage of their department for a palsy. Hence, now it has been reclassified as birth brachial plexus palsy. Okay. So, the questions will not come from obstetric brachial plexus palsy. It will be formed as a birth brachial plexus palsy. There are two things. One is the herbs and the clumkeys. We know herbs point is at the junction of C5, C6 and the suprascapular nerve. Then a clumkeys is from C8 to T1. Okay. Both mechanisms are going to be hyperabduction type of injury. The nerves affected mainly in the herbs are the suprascapular nerve, axillary nerve and the musculocutaneous nerve. Okay. So the deformities is the polysment tip deformity. Okay. The shoulder is going to be adducted, internally rotated. Elbow is going to be pronated, extended fully. Forearm is pronated and internally rotated with the asking for a bribe. That is like policeman step up. In this thing, in Klumpke's paralysis, you're going to have a complete call hand plus harness. Okay. So, The most common cause are the births when they were using forceps or other instrumented deliveries. The treatment for the both being the aeroplane split. So remember guys, birth brachial plexus palsy, it is of two types, Klumpke's and ERBS. ERBS is C5, C6 junction. The nerves affected are suprascapular nerve, axillary nerve, musculocutaneous nerve. Here it is C8 and T1. So you're going to have Clawhand and Horner's. Okay. Here you're going to have the policeman's tip deformity, treatment being the aeroplane split. Okay. So now let's have a brief discussion about the brachial plexus and solve the questions from the three major nerves. One of the favorite things in orthopedics which keeps coming in all the exams and where you can score full marks. Okay. So brachial plexus, I am sure in anatomy it would have been covered. I'll just give an overview. Okay. In root wise, we are going to have C5, C6, C7, C8 and T1 roots. Okay. From there, you're going to arise the upper trunk, middle trunk and the lower trunk. Upper trunk is formed from C5 and C6. The middle trunk arises from C7 and lower trunk is formed from C8 and T1. Each of the trunks divide into the anterior and posterior division respectively. All of the posterior division will combine together to form the posterior cord. The anterior division of the lower trunk will continue as the medial cord. The anterior division of the upper and the middle trunk will continue as the lateral cord. Okay. So the branches are the first, the posterior cord gives rise to the ultra. Okay. So it's going to be upper subscapular, lower subscapular, thoracodorsal nerve, radial nerve and axillary nerve. The medial one is going to be the M4U, that is medial cutaneous nerve of arm, forearm, median pectoral nerve and medial root of median nerve and the ulnar nerve. And the lateral cord is going to give rise to the LML. Okay, lateral pectoral nerve, musculocutaneous nerve and lateral root of the median nerve. Very easy to remember. This is covered in anatomy as well. I am just giving a brush up on that. So the important nerves as per us is the median nerve, ulnar nerve and the radial nerve, based on which questions come for us. Alright. So other important question that can come is the long thoracic nerve of Bell. You know, it causes serratus anterior weakness leading to winging of scapula. The musculocutaneous nerve will supply the coracobrachialis, brachialis and the biceps brachii. The axillary nerve is important, gets injured in the shoulder dislocation. It supplies the muscles of deltoid and teres minor. The typical sensory region for the axillary nerve is a regimental batch area on the shoulder. Alright. Now let us look at the important nerves. Okay. A 40-year-old woman with a laceration to the wrist, okay, presents with weakness in thumb opposition, inability to perform the OK sign. She also has sensory loss in the palmar surface of the first three fingers. Which of the following is the most characteristic sign? Here, injury at what level? That is important. Okay, injury at wrist. So, OK sign. Inability to perform OK sign means it is anterior interosseous nerve injury. Sensory loss is given. What is the other characteristic feature? Is the ape thumb. Okay. Why do I say ape thumb? Is because all the thenars are gone. So since the thenars are gone, only the adductor pollicis is functioning. That is by the ulnar nerve. Hence, ape thumb is the answer for this question. Now let us look at the median nerve slightly in detail. Okay, it's very important, right? So median nerve is also known as the labrador's nerve. All right. Sensory on the palmar, it is always the palmar surface of the first two, 1, 2, 3 fingers. On dorsum, it is only the tips of the 1, 2, 3 fingers, only tips. Rest everything is by the radial nerve. Remember, guys. Okay. So motor wise, very easy to remember. Okay. In arm, there are no branches. Okay. In forearm, all the flexor compartment except only two. Flexor carpi ulnaris and median half of the flexor digitorum profundus. In hand, all the thenar muscles except the adductor pollicis. So these are the, if you remember the exceptions, very easy to remember. All the muscles in the forearm compartment except flexor carpi ulnaris and median half of the FTP. In the hand, all the thenar except the adductor pollicis. Okay. So, injury level, this is what we have to know. First, let's look at the wrist level. In wrist level, what will happen is the anterior interosseous nerve is completely gone. So, thenar is completely wasted. Since thenar is wasted, all the muscle leading to thumb abduction, flexion, and opposition are lost. So, only the thumb can be in adducted position leading to ape thumb deformity at the wrist level. Okay. Now, elbow level, in the other test, classical testing for the wrist level is the pen test, or for the abductor pollicis longus. You keep a pen and ask him to touch the pen. If he is not able to abduct, this is a classical example for the abductor pollicis longus or the pen test. Okay. So for wrist level, we have the ape thumb and the pen test. Okay. At elbow level, slightly difficult. Okay, slightly different. All right, depending upon where the sign is. Okay. See, when the lesion is proximal median nerve, above the anterior intraosseous nerve, okay, that means FDP is gone. Okay, when you ask the patient to make a fist, because of the loss of the FDP of the medial or of the first 1, 2 and 3 fingers, it remains extended. So that is called as pointing index, Benedict sign, or Oscar's clasp sign. Rather, when the distal median nerve lesion is involved, that is, it affects below the AA nerve, anterior intraosseous nerve origin, the FDP is very well intact. So, from a closed fist, when you're asking to extend all the fingers, since the FDP is overacting compared to the other muscles, he will not be able to extend the first 1, 2, 3 fingers correctly. That will lead to median clawing. Okay, so the lesion is above the anterior intraosseous nerve or the elbow level. Because of the activity, loss of activity of FDP, you are going to have Benedict sign. And since lesion is below the level of the anterior intraosseous nerve, and you're going to get affect the FDP, so hence you're going to have the median clawing. All right. So the anterior intraosseous injury, typically you will not be able to do an OK sign. So that's the typical of anterior intraosseous nerve and ape thumb deformity. Okay. So the most specific test for carpal tunnel is the Phalen's test. Yeah. And a female patient complains of tingling and numbness in the lateral 3.5 fingers. She usually wakes up the night of pain. She gets relieved by hanging her hands at the edge of the bed. What is the correct pair of diagnosis? So, night pain, median half of fingers. So, characteristic of carpal tunnel syndrome. Okay, carpal tunnel, and the important sign is Durkin signs or Phalen's test. Okay. So, all of the following are predictive factors for correctly diagnosing carpal tunnel syndrome except abnormal SEMS Western and wrist neutral portion. This is one test. We'll talk about that. Positive median nerve compression test. Yes, this is definitely. Presence of night pain. Yes. Loss of small digit adduction. We all know adduction and abduction are caused by the ulnar nerve. So this is the sign. So even though you don't know what is the Siemens Weston, you can answer this question by the process of elimination. All right. But the Siemens Weston is to measure the intensity of the nerve, and that is also important measure for carpal tunnel. Okay. All right. So carpal tunnel syndrome affects females more than the males. There will be burning and tingling sensation along with numbness at the night. The investigation of choice becomes a nerve conduction study, and the diagnostic tests are the Phalen's test, Durkin's test, and the Tinel sign. Treatment includes either conservative or surgical release of the carpal tunnel. All right. Other famous entrapment syndromes, you have the cubital tunnel, compression of the ulnar nerve, pin entrapment of the pin nerve between the pronator heads. Guyon's canal is again ulnar nerve, pronator is the median nerve. Kilo-Neville sign is the anterior intraosseous nerve alone against the supracondylar region. Chiralgia parasitica is the superficial radial nerve. Tarsal tunnel, you will have the posterior tibial nerve. These are the other named nerve compression tests. Okay, or you can say that entrapment syndromes. Okay, Guyon's, pronators, Kilo-Neville sign, Chiralgia parasitica. Like you all know that Meralgia parasitica. What is Chiralgia parasitica? Superficial radial nerve. And then the tarsal tunnel. Right. Look at this question. A 55-year-old man presents with numbness on the medial aspect of his leg and foot after a knee surgery. He has no motor deficits, only loss of sensation in the medial aspect of the foot. The medial aspect of the foot is supplied by the saphenous nerve. If you look at the foot, if this is the great toe and the small toes, and this is the ankle, the medial is by the saphenous, and first web space is by the superficial common peroneal. Okay, and sural nerve supplies the lateral part. Okay, so easy to remember. All right. A 55-year-old man presents with symptoms of meralgia parasitica. Okay, including burning pain and tingling over the outer thigh. He has been advised to modify his life. Which of the following management is the most appropriate? Surgical decompression of the surgical? No. You need not immediately start with the surgical decompression. Physical therapy focusing on strengthening? No, that is not going to help the nerve. Avoidance of tight clothings and weight reduction? Yes. Corticosteroid injection into the lumbar spine, not going to affect directly. So the best possible thing is avoidance of tight clothing. So tight clothing compressing the femoral lateral femoral cutaneous nerve is the important cause of meralgia paresthetica. Okay. So book test is usual for the ulnar nerve. We'll discuss about the ulnar nerve in the coming class. Okay. So ulnar, so we saw the medial nerve is also known as the labrador's nerve. Ulnar nerve is also known as the musician's nerve. The sensory is like how we saw on the palmar branch, it supplies the medial to 1.5 of the fingers. On dorsal aspect, it supplies the tip of the little and the middle finger. Okay. So motor, just like the median nerve, in arm it has no branches. In forearm, all the flexor compartment we already saw. So what is the left out thing? Flexor carpi ulnaris and median half of FDP. In hand, hypothenar, then adductor pollicis from the thenar, lumbricals and the intrashed. Okay, lumbricals and intrashed. So we know lumbricals function is flexion of the MCP joints, extension of the interphalangeal joint. Okay. So injury level. So this is very important. Please pay attention to this. Now you'll know what is ulnar paradox. Okay. When the high level injury is gone, okay, that means FDP is also paralyzed. All right. So you will have entire hypothenar loss. So you will not be able to interphalangeal joint flexion will not happen because the FDP, since it's a high level injury, FDP is gone. Therefore, you will have less clawing at high level injury. In lower level injury, that is after the FDPs are spared, the flexor digitorum profundus muscles will pronounce the clawing of the little two terminal fingers, leading to increased clawing. So, the lower injury will produce more clawing compared with the higher level. Hence, this is known as ulnar paradox. In median nerve also it is the same. In here also it is the same. Okay. Remember, the clawing is mainly because of the activity of the FDP. Wherever FDP is also gone, you cannot get much clawing. So FDP is present, you will get more clawing. So that is the concept behind the ulnar paradox. Okay. The important clinical tests are the card test is for the palmar intrashed. Palmar intrashed, we know it is pad adduction. Dorsal intrashed is dab abduction, Igawa test or Wartenberg sign. And the whole book holding sign is for the format sign or book test, where you are testing the adductor pollicis. Usually we hold a book or something using the adductor action, whereas if the adductor pollicis is not functioning, we tend to hold it by FPL, flexor pollicis longus, rather than using the adductor pollicis. So that is an example for the format sign or the book test. Okay. Now the next interesting nerve is the radial nerve. This is the most commonly injured nerve, but the best prognosis nerve. Okay, sensory, the autonomous zone is the anatomical snuff box. Okay, so motor, this nerve has supply in the axilla. In the axilla, it supplies the long head of triceps. At the spiral glove, it supplies the lateral and medial head of triceps. And the intrinsic compartment, it supplies the extensor, all the extensor muscles. Okay, after the elbow, it supplies the extensor muscles. All right. Now, what are the injury level? How do we find? Okay, if it is a very high, you will lose everything, right? From elbow drop, you will not be able to flex the extend the elbow, wrist drop and finger drop. If it is at the radial groove, elbow extension will be spared because the long head of triceps is functioning. So you will have wrist drop and finger drop. If it is the pinna in the forearm injury, you are going to have only finger and thumb drop. Okay. So that is the concept between the higher the radial nerve palsy, the more the effect, and gradually as we move distal, the drops will become little. Okay. All right. Okay. A patient present with multiple humeral shaft fractures following which a difficulty in flexion, elbow and supination, which he also complains loss of sensation over the lateral side of the forearm. Lateral side of the forearm. What is the nerve? See, mainly flexion of the elbow is by the biceps brachioradialis, okay, and supinatus, they are by the musculocutaneous. So hence that question I had kept, okay, to know about all the nerves. All right, guys, we finished the nerve chapter. Next, we'll proceed with the pediatric chapter. All right, very interesting but very important chapter as well. A lot of questions keep coming from this. All right. All right. Let's go to the questions. A 9-year-old child presents to your clinic with the following deformity of the right arm. Which is the most likely fracture leading to such a defect? Guys, any deformity, I'll give you on this thing. Okay, this is the proximal, this is the distal, and this is the center. Okay. Okay, when the distal portion is coming towards the center, it is always varus. Center, proximal, distal. When the distal portion is going away, it is always valgus. So here if you draw two fragments and this is the center, here you have the distal fragment coming towards. So this is an example for cubitus varus, most commonly caused by supracondylar fracture of the humerus. Okay. The fishtail deformity in a child is seen after the fracture of important sign itself displaced supracondylar fracture of the distal end of the humerus. Okay. Let's read a few things about the supracondylar fracture based on which all the exams, some or the other, one or the other questions end up coming. Okay. So it is the most common fracture around the elbow in the children. The most common mechanism is push. Push is nothing but fall on outstretched hand. Okay. So the most common mechanism is hyperextension. Okay. So important bony landmarks what you have to understand regarding the elbow is the lateral epicondyle, medial epicondyle and the olecranon process. Okay. When the fracture is supracondylar means the 3-point relationship will be maintained. As the name implies, the condyle above, the fracture is above the condyle. Whereas in other type of injuries like elbow dislocation and terrible triad injury, the 3-point relationship is lost. Okay, this is very, very important to understand. Okay. In supracondylar fracture, since the fracture line is above the above the condyles, the 3-point bony relationship is maintained. Okay. Types can be extension type, which is most common than the flexion. In extension type, what you have to understand is the distal fragment. See, distal fragment is extended. Here, the distal fragment is pressed, flexed distal fragment. Based on that, we decide whether it is extension type or flexion type. Important classification being the Gartland classification. They give type 1 where you only see the air shadow. Type 2 is the posterior hinge is present. Type 3B is extension type where the posterior hinge is also disrupted. Type 3 is severe comminution. Okay. So here hinge present, only the air shadow. Hinge also is lost. Okay, guys. Okay. So reduction assessment is mainly you have to know about the Bowman's angle. Okay. If after you reduce, the Bowman's angle should come to 70 to 75 degrees. How you identify the Bowman's angle is the drain drawn along the shaft of the humerus to a drain drawn up the superior part of the capital. Okay, that angle should be 70 to 75. That means whatever reduction you have obtained is correct. Okay, remember the term Bowman's angle, very important. All right. The treatment would be minor grades, you're going to go POP and reduce. For further grades, you're going to do an open close reduction and K-wire fixation. Okay. Now, what is the important complication based on which a lot of question comes and trick you? It's pulseless pink hand or pulseless white hand, whatever. Let's end the controversy today. All right. See, Gartland type 3 supracondylar fracture with absent radial pulse. This is a separate entity for which we need to know the concept to be able to solve it. Okay. Okay, the keyword is the pulse is not there, but this is either a pink hand or white hand. Pink hand means it is still perfusion is there. So you can do a close reduction and pinning and observe. If it is a white hand, no perfusion, you will have to do an immediate open surgery. Immediate open surgery and repair the brachial artery. Whereas in this case, when it is pink, we could end up with three possibilities. Either after fixing we get no pulse. In that case, your hand becomes white. In that case, you go to do a brachial artery repair. You get no pulse, but the hand is still pink. That means you can still wait and watch. Okay. If the return of pulse later, you can leave it, or if the pulse doesn't return, you have to do an immediate open brachial artery repair. If after fixing with KY there's an immediate pulse, that means you can leave it all alone and your hand is survived. Okay. It could be an pulseless, absent pulseless, pink or white hand. If it is a white hand, you need to do a brachial artery repair. Whereas a pink hand, you can wait. Okay, by doing a K-wire fixation. If immediately after the K-wire the pulse comes, leave it as such. If the pulse doesn't come, do an immediate brachial artery repair. If the pulse doesn't come or the hand still remains pink, then wait and observe and repeat the tests. If on further tests also the capillary is going, you're feeling it to be decreasing, then do an open surgery and repair the brachial artery vessels. Okay. So Gunstone deformity, as I mentioned before, the carrying angle between the humerus axis and the forearm axis. Okay, when the carrying angle is decreased, you get the gunshot deformity. Carrying angle more is called as the cubitus valgus. Okay. So the most common complication of supracondylar fracture is the gunstock deformity or the cubitus varus. So carrying angle decrease means Bowman's angles will be increased. The most common cause of this gunstock deformity is the malreduction. Okay. Now let's solve the next question. Okay, very interesting question. A 12-year-old boy presents with numbness and weakness in his hand. Okay, particularly affecting the little and ring finger. So something with the ulnar nerve. Okay. He has a supracondylar fracture of the humerus 5 years ago. On examination, there is noticeable valgus deformity and wasting of the hypothenar. What is the most likely explanation? So ulnar nerve is affected. So what is here? Ulnar nerve injury is only tardial ulnar nerve. But I will tell you how to solve this also. Since there is a cubitus valgus, you see ulnar nerves running here on the medial aspect. But eventually what happens, because of the valgus deformity, the nerve will get stretched out. So the stretching of the nerve will one day affect him. Okay, that is called as tardy ulnar nerve palsy, meaning late deformity due to late stretching of the nerve. Okay, I hope this point is clear about why tardy ulnar nerve palsy. This is more common with lateral epicondyle fracture than the supracondylar fracture type of injury. Okay. Okay. A 3-year-old child presents with sudden onset of elbow pain after being lifted by the arm. The child refuses to use the affected arm but holds in slight flexion. What is the answer? Sudden one arm lifting. It's only one thing, that is pulled elbow. Okay. The pulled elbow X-ray is usually normal. What do we do is immobilization of the arm. No. We immediately close reduction with hyperpronation and flexion technique, supination flexion technique. What we do is we hold the hand, keep a hand on the radial head, try to push it in, and we hyperpronate or supination followed by flexion. Hyperpronation flexion or supination flexion. That is the immediate management for a pulled elbow. No need to give a POP or do an open surgery. Okay. Match the following. Okay. What is made-lung deformity? Made-lung deformity is where there is a transition on the wrist of the radius. Okay, that is made-lung deformity. Hag-lung deformity is a bony growth over the calcaneum. Buttonhole deformity is rheumatoid arthritis. Gunstock deformity is cubitus varus deformity. Okay. All right. Next important algorithm. After my algorithms for orthopedic orthopedics, my algorithms is essential to solve the pediatric questions. Okay, very important, guys. Pay close attention, with which most of the 99% of the pediatric hip questions you'll be able to solve very easily. Okay. Right. First, okay, in all questions, one common thing they would have mentioned is the gait. Okay. In gait, you look for if it is a non-antalgic gait or an antalgic gait. The moment they say it's a painful gait, you rule out trauma and systemic features to rule out infections, septic arthritis and osteomyelitis. Okay, trauma systemic features should come. Okay, the moment it is a non-antalgic gait, you look for what is that gait. If it's a Trendelenburg gait or an equinus gait. Trendelenburg gait, non-antalgic, from the child it will be there, so it is most common is DDH. If it is an equinus gait, put it at a CTEV. Okay. See, non-antalgic is something that is developed since child. That's how it has been adapted. Okay. There are only two possibilities. DDH is a Trendelenburg gait. If it is an equinus gait, so for CTEV. Okay. If it is an analgesic gait, you have ruled out trauma and infection. The next thing to look at is the age. Age is less than 10 years, go for Perthes. More than 10 years, go for Skiffy. That's all, guys. So the 6 basic pathologies are going to be DDH, CTEV, Perthes, Skiffy, trauma and infection, the pediatric hip. So what did I say? If it is a non-altachic gait, that means something that has to be present since birth. Since birth is two conditions, developmental dysplasia of hip and CTEV. In developmental dysplasia of it is going to be Trendelenburg gait. In CTEV it is going to be equinus gait. Okay. Then if it is an antalgic gait, you are going to first rule out trauma and infection. After ruling them, look at the age. Once the age is more than 10 years, think in terms of Skiffy. If less than 10 years, think in terms of Perthes disease. Okay. Now, after knowing the algorithm, the next areas where they're testing is with the X-rays. Okay. Follow me and understand the important hip X-rays. Okay. So this is the pediatric hip where you have to appreciate the pelvis and the femur. Okay. The first line which you should know is the Hillgren's line. This is an H for hill. Okay. H for horizontal. A horizontal line drawn at the junction of the triradiate cartilage. Okay. Normally, the head will be inferior to it. If the head is superior, it is for DDH. Now, if you draw a perpendicular to the Hillgren's lines at the lateral border of the acetabulum, again the head will be inside normally. If it is outside, it is an example for DDH. So, Hillgren's line and Perkins line is for DDH. Okay. The next is the Shenton's line. Shenton's line is for mainly disrupted DDH and neck of femur fracture. Next is the important line is the Kleene line for Skiffy. In Kleene line, you draw a line along the outer margin of the neck to the center of the acetabulum. Okay, outer margin of the neck to the center of the acetabulum. The neck will usually be present inside. The neck is outside. This is an example for Skiffy. So I mean the head is outside example for Skiffy. So Hillgren's lines, Kleene lines, Hillgren's lines, Perkins lines and Kleene line. Okay. Hillgren's and Perkins is for DDH, Kleene line is for Skiffy. In both, the pathology is when the head is outside only. Okay. When the head lies outside, it causes some pathology, either Skiffy or DDH. Okay. Now discuss a few points about DDH as a whole. Developmental dysplasia of hip, also known as congenital developmental dysplasia. It's an idiopathic spontaneous subluxation of the femoral head. Okay, the femoral gets subluxed. Okay, the most common mechanism may be either it can be because of the acetabulum or the femoral head pathology. Acetabulum wise, the acetabulum can be shallow or convex. In femoral head, there could be a large limbus or lax ligamentous teres. Mostly DDH develops in female, firstborn female child, 20% bilateral, and left is more common than bilateral, more common than right. Okay. Firstborn female child of breech presentation is the rule. First point, firstborn female child with brief presentation is the rule for DDH. Okay. So, investigations, remember this age-wise guys, since this is all developmental, immediately less than 6 months, you cannot take an X-ray because no bone is clearly seen. You have to do an USG. In USG, you will find increased beta and decreased alpha angle. Then after 6 months, you can do an X-ray. And treatment-wise, 0 to 6 months, when you cannot do an X-ray, you can only put a Pavlik harness. After 6 months, you can try to reduce as you're seeing the X-ray and put a cast. Beyond 18 to 36 months, you can do a valgus derotation osteotomy, and more than 3 and 10 years, you'll have to do a pelvic osteotomy. Okay. Remember it, since it is a developmental pathology, less than 6 months, you do an USG and look for increased beta and decreased alpha angle, and more than 6 months, you can look for the X-ray lines. So treatment wise also, less than 6 months, you can only give a Pavlik harness. 6 to 18 months, you can try to reduce it. And beyond 18 months, you do a VDRO, valgus derotation osteotomy. And then you always do a, beyond 3 years and 5 years, you go salvage pelvic osteotomy, like Saltus osteotomy or a THR. That is what we have to do. Okay, this is regarding DDH. So surgery of steps of DDH in a child of 2 years is, what do you do first? First you get the skin subcutaneous tissue, and then what you'll be able to do, you'll see the capsule. So you remove the capsule first. Once the capsule goes, you'll be able to appreciate the true acetabulum. Then you do a osteotomy, femoral osteotomy, and then you place the head back. Okay, so A first, then C, then B and D. Answer is A. The figure shows a radiograph of an otherwise healthy Caucasian 5-year-old boy who has a painless limb. What is the best treatment option? See, less than 10 years. That means I told it is Perthes. They will have an antalgic gait. But here it is given as a healthy painless limb. Okay, non-antalgic. That means it has not yet formed. So what is the clue in the X-ray is that compared to the heads, this is small. So all these point towards Perthes. So a non-antalgic Perthes means it is not significant or symptomatic. So you can just wait and watch with physical therapy and ROM. So mostly they recover after 9 years to 10 years. If it is significant, then you'll have to do an operation. All right. Next question. A 10-year-old child presents with hip pain and limping that worsens with activity. See, the presents with hip pain and limping that presents worsens with activity. Improves with rest. What is this? The head itself is not there. So it is Perthes. Okay. So Perthes is normal hip, just like avascular necrosis of the adults. Ischemia occurs. The soft head undergoes resorption, leading to head resorption. Okay. That will lead to loss of the head. Next question. Figure 39A and 39B show the current radiographs of an 8-year-old girl who had pain in the left thigh for the past 3 months. Okay, pain is there, antalgic. After 8-year-old girl. She is recently diagnosed hypothyroidism and started treatment 1 week back. Hypothyroid, that means endocrine. So, hip pathology with endocrine is only skiffy in this world. Okay. Examination refers abductor deficiency. Okay, she lacks 33 internal rotation and abduction deficiency. Management should consist of. See, what is the thing here is, here the head is slipping, so skiffy, and this is normal. But since one side it is slipping and the endocrine problems are also there, we have to prophylactically pin both. Close reduction and pinning of left hip also. Oh, sorry. In situ pinning of both the hips. So that is the answer for this question. You'll have to pin both the hips. So since that is also more prone for going in for skiffy. Okay. So what is skiffy? Skiffy is slipped capital femoral epiphysis, but actually this is a misnomer. Okay. Why? Because the head doesn't slip. It is the neck that slips. supero and laterally. Okay, the neck goes suprolaterally, so head will come infromedially. Okay, that is a misnomer. It occurs in the zone of growth plate, hypertrophic zone of growth plate, or zone of provisional calcification. All the pathologies in luckily in orthopedics, pediatrics, they all occur in this only. Scurvy, skiffy, perthes, all occurs in zone of provisional calcification or hypertrophic zone of the growth plate. Okay, hypertrophic zone of the growth plate or zone of provisional calcification. Okay, very important. All right. Here, understand this. The neck is slipping supralaterally, but actually misnomer, we are saying the head is coming medio and internal. Okay. All right. Next, come to the major portion of the pediatric one, where in all the exams you get a question. All right, from this topic. All right. Okay. See, regarding CTV, guys, I've tried to give a easy thing for you to understand. Okay. Remember two words possible for CTV. We'll try to combine everything under that. Okay. CTEV, we know is the diagnosis. So for treatment, what we use is CAVE. You just remember these two words. CTEV. Congenital. Talipes means what? So foot deformity. E means the equinus. Equinus occurs at which joint? Ankle joint deformity, foot deformity. V is the varus. Varus occurs at which joint? Forefoot. Subtalar joint inversion. So what are all the joints involved? Ankle joint and the subtalar joint. Where all the deformity is there? Forefoot, midfoot and the hind foot with the ankle joint. Okay. This is the from the word CTEV I have coined this, not from anywhere else. Okay. So this is the classical picture of CTEV. You will never go wrong. Equinus deformity, inversion, supination and adduction. Okay. So for the pathology, I asked you to remember one more word called as CAVE. This is both for treatment and pathology. Okay. First is pathology is C for CAVE. We have to correct in this order only. Why do you think there's a curve here? Because increased action of the flexors. Okay, increased action of the flexors. A is adduction. Why is there a adduction? The subtalar joint is inverted and adducted by the action of the tibialis posterior. And V is varus. Again adduction, varus is by the tibialis posterior, subtalar joint. And E is equinus is because of the action of the tendo Achilles. Okay. So tibialis posterior, FHL, FDL and tendo Achilles. Both by the terminologies only we are remembering. Nothing else to mug up. Okay. CTEV you can coin, and what are all the deformities present, which joints are involved. Ankle joint and subtalar joints are involved. And for the deformities you go for cavus, CAVE, adduction, varus and equinus. Okay. So how do we correct it? Again by the Ponseti technique is CAVE. First you correct the cave for 1 week, then adduction for 1 week, varus for 1 week and equinus at the last. If you correct the equinus at the beginning, you will end up with a rocker bottom foot. So always equinus has to be corrected at the last. The manipulation should begin by around 2 weeks after birth. Okay. In investigation wise, if you can't remember, okay, there's something called as Kite's angle. Okay, Kite's angle is decreased in CTEV. Okay, there are two angles basically, the talus and the calcaneum angle and the talus and the first metatarsal angle. So talocalcaneus angle is decreased, talometatarsal angle is also decreased in the CTEV. Okay. So 2 months, after 2 months you do manipulation, 2 weeks you do manipulation, after 2 weeks you start putting cast. After that what you do, up to the 1 year or the child starts walking, you put the DB splint, okay, in the night. If the child starts walking, you will have to give a CTEV shoes, okay. Then in 1 year you can do a posteromedial soft tissue release. Then if it is failure after 3 to 5 years, you can think about the bony procedures like Delvin-Evans procedure, okay. Beyond 5 years, you can think about the osteotomy. Okay. But beyond 10 years, there's no hope left than to do what? Triple orthodosis. So manipulation, CTEV issues, then look for the posteromedial soft tissue release, then beyond 5 years, you look for the Delvin's osteotomy, Delvin Evans osteotomy, then beyond 5 years or 10 years, you'll have to do for a triple fusion. So other treatment modalities for CTEV includes Ilizarvo and JUS. Okay. Now let's solve some important questions from CTEV. Okay. Evaluate the following statements with respect to CTEV. 50% cases are in males and are bilateral. We don't know. Let's wait. Forefoot is adducted and supinated. Okay, correct. With Ponseti's technique, correction is up to 90%. Definitely. Equinus should be corrected first. No, equinus at the last. So whatever it has 4 is ruled out. So answer is 1 and 3 is correct, or 1, 2 and 3 is correct. So we know 1 and 3 are definitely correct. No, we know 2 and 3 are definitely correct. Okay. So with the option of ruling out, we say even if we don't know if 50% cases are in male and bilateral, we assure that 1, 2, 3 are correct. Okay. First deformity which is corrected is for CTEV. What is the deformity correction mnemonic? CAVE. That's all. CTEV, cave. Okay. First is caves. A newborn is diagnosed with congenital talipes equinovarus. The physician is planning to start treatment to correct the deformity. What is the most effective initial management strategy? What is the most appropriate initial management? Surgical casing, bracing, observation. First bracing is always physiotherapy, or better terminology is manipulation. Okay guys, we'll have a small break and come back. Okay. Hi guys, welcome back. Okay, now the last two topics of discussion is from advanced orthopedics. So I wanted to cover arthroscopy topics as well as spine topics. Guys, what has happened is since orthopedics has evolved so much, it is expanding rapidly. There are certain fellowship topics like for arthroscopy, there's a fellowship, arthroplasty fellowship, orthopedic oncology fellowship, and spine has become a separate even in a MCH course. But I have been noticing that in the INI-CET exams recently, a lot of questions have started coming from these advanced topics. So no more it is sufficient for you guys to rely heavily on the basic topics to get you all the marks. You will have to be thorough with the advanced topics. So I've just focused on the repeated questions which has come from these advanced topics and try to give you guys an overall picture about arthroscopy and spine surgery. All right, let's discuss about those in further. Okay. So first question, in case of a meniscal tear for repair, which of the following zones of meniscus shows best healing potential? The answer for this is red zone. I will discuss about that in the theory discussion. All right. Understand about the meniscus. Okay. The meniscus is also the cushion of the knee joint. Okay. There are two menisci, medial menisci and the lateral menisci. Okay. They provide rotational stabilization and, like I mentioned before, cushions or shock absorbers. Okay. Regarding the blood supply, you see the outer zone has good blood supply or called as red zone. They have more potential for healing. Whereas inner you go, it becomes white, very poor healing with less blood supply. Okay. So the types of tears of the meniscus are the vertical tear, which can progress if it becomes big to a bucket handle tear. A transverse tear, if it progresses, becomes the parrot beak tear. A peripheral tear, if it progresses, becomes a flap tear. Okay, these are the various types of meniscal tears. Okay. The test for the meniscal injury is the McMurray's test. Okay, very important. And the other test is the Apley's grinding test. How do you perform the McMurray's test? Is you flex the knee, and for the medial meniscus you will have to do external rotation and extend, whereas for the lateral meniscus you will have to do internal rotation and extend. The concept is you're stressing on the meniscus. Okay, for the medial meniscus and the lateral meniscus. That is about the meniscus. The injury shown in the radiograph can result in, if I zoom it, you will be able to see the bony fragment. This is nothing but Sigond fracture. Sigond fracture are synonymous with ACL injury, cruciate ligament injury. Okay. A 25-year-old athlete presents with pain and swelling in the knee after twisting it during a soccer match. He describes hearing a pop at the time of injury and has since experienced instability in walking. There's a positive Latchman's test. The answer for this question is the anterior cruciate ligament. We have finished the menisci. Now we are coming towards the cruciate ligaments. Okay. We saw the menisci as rotational plane stabilizers. The cruciate being the sagittal plane stabilizers. Okay. Among the cruciates, the most important one is the ACL. It prevents the anterior translation of the tibia. The difficulty is climbing downstairs. Okay, very important, difficulty in climbing downstairs. The tests are anterior drawer test, Latchman test, and the Lilly's test. In emergency or acute phase, you can do only Latchman's. This is anterior drawer cannot be done, or Lilly's cannot be done. Okay. The important triad associated with ACL injury is the Odongo triad, that is ACL plus medial meniscus plus the MCL. This is one of the common sequence of injury. And like in the question what we saw, the Sigon fracture, it is the avulsion fracture of the proximal tibial plateau, lateral tibial plateau margin. It is synonymous with ACL injury. Okay. Next important cruciate ligament is the posterior cruciate ligament. It prevents the tibia from falling backwards, pain on going upwards. That was pain on going downwards, climbing downstairs. This is climbing upstairs. Okay. So the investigation, so the clinical test, like we saw the anterior drawer test, we have the posterior drawer test here, and reverse pivot shift test. Okay. Then the important other injury, which is apart from this cruciates and the meniscus, are which many ignore, is the posterolateral corner injury, PLC injury we say. Okay. This is very important because if this isn't addressed, you will not get a complete knee stability. Okay. The various components of the PLCs are popliteofibular ligament, fibular collateral ligament, popliteus tendon, and lateral gastroc tendon. Okay. The important test for the PLC complex posterolateral injury is the dial test. Okay. So how do you manage the knee ligament injuries? Okay. The investigation of choice becomes MRI as well. Okay. The treatment is, if it is a multi-ligamentous injury, always operate, no doubt. Okay. If it is a isolated injury, if it's a mild grade, grade 1 and 2, you conserve. If it's a high grade, greater than or equal to 3, you have to repair it. If it is an ACL, you do an ACL reconstruction using either the patellotendon bone graft or a hamstring. If it is a meniscus, in the red zone, you try to repair. White zone, you do an excision. Posterior cruciate ligament, you do a reconstruction. PLC, you try to repair and reconstruct. Okay. The graft options are hamstring, most commonly used, patellotendon bone graft, which is the best strength, and the other graft is the peroneus longus from the foot, extra graft. Okay. Always keep this as a bystander, right? Most common use is the hamstring. The best strength will give you by the bone patellar tendon graft, and the extra is always the peroneus longus. Alright. So this covers the sports injuries that can commonly occur around the knee. Now let us look at the sports related injuries that can commonly occur around the shoulder. Alright. Many questions keep coming from this. Okay. Recurrent dislocations are least commonly seen. Okay. Which joint? Shoulder, very common. Okay. Hip we see, ankle we see, every time we subluxate. So the least common is the patellar dislocation. Okay. So let's look at the shoulder dislocation first. Okay. Shoulder. The shoulder joint is actually a very unstable joint because the head is 4 times larger than the glenoid. Because of this itself, there is increased mobility but decreased stability. Therefore, this becomes a most common dislocated joint in the body. To prevent this dislocation, God naturally, nature has given us stabilizers. Okay. Static stabilizers and dynamic stabilizers. The static stabilizers are the labrum, capsules. The dynamic stabilizers, most important, are the rotator cuff muscles. Okay. So the shoulder is weakest at the inferior joint, but most common dislocation is the anterior dislocation. Okay. So what are the rotator cuff muscles? Supraspinatus, infraspinatus, teres minor, and the subscapularis. These are the rotator cuff. So most common joint dislocation is anterior, but it is least protected in the inferior only. But still anterior is the most commonly dislocated. Okay. So dislocation type, like how we saw in the hip, in shoulder it is anterior dislocation and posterior dislocation. Okay. And inferior also. So anterior dislocation, the arm is going to be in abducted and externally rotated, how in the pelvis also. In posterior dislocation is going to have adduction and internally rotation, and inferior dislocation is going to be in hyperabduction position. Okay. The most common being the anterior dislocation. So anterior dislocation, the most common subtype is subcoracoid. Most common nerve injury is the axillary nerve injury. Most common complication is the recurrent shoulder dislocation. The tests, clinical tests to find out the dislocation are the Dugas test, where you are not able to touch the opposite side shoulder by the affected limb. The Callaway's measure, where you measure the girth of the shoulder decreases with dislocation, and the Hamilton ruler test. Hamilton ruler test, you keep a ruler on the lateral epicondyle. Because of the push, you will be able to place the ruler on the deltoid. In dislocation, you will not be able to have the contour, so this will go upwards. You will not be able to place the ruler. So these are the basic tests to find out about dislocation: Dugas test, Callaway's maneuver, and Hamilton's ruler test. Okay. So this is a typical X-ray for anterior dislocation. Okay. You see the head has come anterior to the wall of the glenoid. Okay, slightly inferior also. So this is the common type also, subcoracoid type. Okay. The reduction technique is by the coaches or the team technique, where you flex the elbow at 90 degrees, you externally rotate and then adduct and internally rotate. Flex, externally rotate, adduct and internally rotate. Okay. The other techniques are the Stimson's gravity technique or the Hippocrates maneuver. Okay, these are all the other techniques. The most common complication is when the dislocation happens, there could be bony injuries. If it occurs in the glenoid, it is called as the Qbanks, that is usually antero-inferior, and Hill-Sachs is the posteromedial. If the lesions are large, Hill-Sachs or Qbanks, they could lead to recurrent shoulder dislocation. So that is called as TUBS. What do you mean by TUBS? Traumatic unidirectional dislocation with Qbanks that requires surgery. Okay. So the treatment is, so Qbanks is where the glenoid is affected. If the Qbanks is small, only labral Qbanks, you can do an arthroscopic Qbanks repair with capsule. You can just tighten the capsule over the Qbanks area. If it is a larger bony Qbanks, you will have to do a Latarjet procedure. Take a coracoid and add it to the glenoid. Okay, if the Qbanks is only ligamentous, you do, and just remember, arthroscopy is common for everything. You just fill the gap with the capsule. If it is large, you need a bony attachment. So you take the glenoid and coracoid and add it to the glenoid. Okay, this is for TUBS, traumatic unidirectional dislocation with Qbanks that requires surgery. Okay. If it is the case of a Hill-Sachs, you do a remplissage, okay, where what do you do is the infraspinatus tendon is sutured on the defect. You just pull up the tendon, fill the gap and fix it with a suture anchor or a remplissage. So what are all the common surgery that's being done? Labral Qbanks repair with capsular shift, bony Qbanks with Latarjet, or Hill-Sachs lesion fixing with the remplissage lesion. Okay, these are the commonly performed surgeries for unidirectional instability involving a bony Hill-Sachs and Qbanks lesion. I hope this is clear. Okay. Next type of dislocation is the posterior dislocation. This is rare compared to anterior dislocation. Okay, the most common cause is electric shock or seizures. In X-ray wise, you will have the characteristic light bulb sign. How do you say it? Is flexion, adduction, and internal rotated. Okay, the bony deformities possible are the reverse Qbanks and reverse Hill-Sachs. Okay, and treatment is traction, and you try to externally rotate to reduce. If not coming, then you'll have to open and reduce. Okay. All right. A 20-year-old gymnast complains of chronic bilateral shoulder instability. Bilateral chronic. On examination, the shoulder can be dislocated in anterior, posterior and inferior, all directions. Which of the following management is the most appropriate? Bankard, Latarje, glenoid, no. The best option for him where there's universal instability is just physical therapy. Okay, no definitive surgery available. So you just have to do a physical therapy to focus on rotator cuff or dynamic stabilizer strengthening. Okay, dynamic stabilizer strengthening is to be done. Look at next question. A 45-year-old construction worker presents to the emergency department after falling from scaffolding. His arm is stuck in a overhead position. So, overhead is nothing but hyperabduction. So, hyperabduction is inferior dislocation. Most commonly injured nerve in shoulder dislocation is the axillary nerve. Okay, no doubt about that. Okay, guys. Okay, clear with that? A 30-year-old male presents to the emergency department after a fall from his bike, landing on his outstretched arm. On examination, his shoulder appears squared with a noticeable loss of contour and prominence of the acromion. X-ray confirms anterior shoulder dislocation. Which of the following is the appropriate stepwise method dislocation using the Kocher's method? I told you. In Kocher's method, it is flexion of the elbow to 90 degrees, external rotation, adduction and internal rotation. See, each and everything has come as a question for you guys. And they are testing your knowledge on advanced topics. So, you can no more afford to relax with the basic topics. If you want 6 on 6, you have to master the advanced topics. Okay. Okay. A 40-year-old man presents with shoulder pain and reduced range of motion after an electrical shock. He is unable to externally rotate his shoulders. X-ray shows the characteristic light bulb sign. Which of the following is the most appropriate next step? I would say the most appropriate next step is CT scan. But since they have given the scapular Y view, suggest a scapular Y view because CT is more radiation and increased cost. If scapular Y view is not given, then the second best answer would be the CT scan of the shoulder. But most of the areas in day-to-day practice, we go ahead directly with the CT scan. Okay. All right. Next question. The painful arc syndrome is 90 to 120 degree syndrome is seen in mid initial full range overhead. The answer is overhead abduction. Okay. So what is this painful arc is? You can notice that the supraspinatus tendon gets compressed between the humeral head and acromion. This is the most common cause of shoulder pain. Okay, the rotator cuff gets impinged, leading to pain. The pain is from 90 degree to 180 degree. Okay. The important name tests are the Nice test and the Hawkins-Kennedy test. Okay. So you can either conserve it or arthroscopically treat it. In arthroplasty, we will discuss more about the types of implants in the image-based section. Now, few questions that has come, hardly 1 or 2 questions only, so not much like the sports injuries, so that also we'll discuss. Okay. A 65-year-old woman underwent total knee replacement 3 weeks ago. She now presents with increased pain, warmth and swelling around the knee. Okay, what is the most appropriate step? So, what does she suffer from? Increased pain, warmth and swelling. So, some kind of infection is there. So, immediately for infection, what do you have to do? You have to do a start broad spectrum antibiotics and aspirate the joint for the culture to find out what it is. Okay. And if it is positive for infection, You give 2 weeks antibiotics, not settling. You do first is tibial tray exchange, tibial liner exchange. Then in second stage, still there is no improvement, you do a implant exit. Okay, and plus or minus arthrodesis. But mostly it will improve by the liner exchange stage itself. Okay. A patient underwent a posteriorly stabilized total knee arthroplasty several months ago for primary osteoarthritis. The patient develops a painless clunk when bringing the knee into extension from flexion. Which of the following is associated? See, in PS knee, you are going to have in the tibial tray something like this. Okay, PS knee. That is going to lock against the femoral component. So, when this hinges, why? Because if the femoral component is large, then there will be a hinging. Okay. So, the answer for this is the large femoral box. This happens in PS knee. When we discuss in the image based questions, I'll cover them in detail for you guys. Okay. Alright guys. Alright. Let's move on to the next advanced topic of spine. In spine, already we have covered infections. So that is settled. But apart from infection, there is so many topics to be discussed with spinal cord injuries, that is the acute or hot topics, and then about the listhesis and the scoliosis and the cold topics. Okay, since questions have been asked from all these sessions, that too in the recent exams, we cannot afford to leave them out. But like in basics, if you need not master the spine, or as a whole if you have an idea, spine is like mathematics guys. You can never go in mathematics if the formula you need not even know all the you should need not have worked out all the questions in that particular area. Only if you know the formula, all the questions you will be able to answer. Similar to that is spine. Okay, my goal today is to make you guys understand what the formula for spine is. Me being a spine surgeon, I'll try to give you all my inputs as possible. Okay, all right, let's begin. Okay, a 55-year-old male presents with severe backache for the past 10 days and urinary incontinence is also there. With a history of intervertebral disc prolapse, there is no history of fever or weight loss. What is the probable diagnosis? See guys, see, if you take a spine, this is at L1 or L2. Okay, the spinal cord. Here is the conus, the terminating part, and after this is the cauda equina. When there's a large disc pressing, see, spine will have several nerve roots, okay, just coming out. The disc usually will be compressing the nerves. If it is a very large disc and compresses everything, when you sustain urinary incontinence, then it is a true emergency. That incontinence can happen only in two conditions, either cauda equina or conus medullaris. Okay. Otherwise, disc will only give rise to sciatica or the radiating pain. Okay. And weakness. When bowel and bladder is affected, you have to intervene emergently, so either the cauda equina or the conus medullaris. Which of the following is not a feature of Brown-Sequard syndrome? Okay. So the answer for this is complete transection of the spinal cord is not a feature. Ipsilateral aorta vibration, yes. Contralateral pain and temperature, yes. Ipsilateral aorta proprioception. It is a hemisection of the spinal cord. Now let us discuss about the spine in detail. Okay. See, spinal cord injury. The most common site of injury is the cervical spine due to very tight packing space. Okay. So the patient comes to casualty. Okay, guys, just like any other injury, you have to deal with spine. Okay, the questions can come from this also since they're focusing on polytrauma. Okay, you follow the ATLS program, that is ABCDE, airway breathing, and you figure out the spinal cord injury. Now, spinal cord injury, there are two possibilities. Okay, either the patient can be in spinal shock or without the shock. What is spinal shock is, it is due to autonomic dysregulation, where you will have decreased BP, decreased heart rate, and flaccid limbs. This can last up to a period of 24 to 48 hours only. Okay, and how do you test it? Coming back is the bulbocavernous reflex for the males and the tugging of Foley's catheter for the females. After this has come, then you identify what level the injury is. Okay, imagine like this. A spine patient is coming to in the casualty and both lower limbs are injured. Immediately you shift him for MRI or whatever, but you know that BP, everything is unstable. BP is low and heart rate is low, not a feature of hypovolemic shock. In that case, you can suspect a case of neurogenic shock due to autonomic dysregulation. In that, you can wait up to a period of 24 to 48 hours giving steroids for the patient and see for recovery. Once the patient starts recovering, how do you determine that? Bulbocavernous reflex of the male or tugging of the Foley's catheter in the female. You will see a contraction. Alright. When that comes, that is the time you will have to determine the location or the level of spinal injury. Okay. For that, we have the scale called as Asia scale or the Asia chart. Okay. In Asia chart, we have the chance to mention the exact motor level, sensory level, and neurological level. Okay. So the motor level is at what level? For example, L2 or L3, where the muscle power are greater than 3. The sensory level is a key areas where sensations is preserved. Okay. The neurological level is the most caudal segment, the distal most segment with normal sensory and anti-gravity muscle function. Okay. These three things you determine to determine where the injury is. For example, if it is affecting only L4, you will have only dorsiflexion weakness. Okay, rest everything will be spared above that. Okay, so to determine the level of the lesion, you go into determining of the neurological level, and then you proceed with an X-ray and MRI. Okay, can questions come from this? Yes. In the advanced topics, when they are testing you, they could ask you the question regarding Asia chart, or at least the name Asia chart, where you document the motor level, sensory level, and the neurological level. Okay. Now, in the just overview, if you are looking at the spinal cord injury, the how you classify spinal cord injury is like this. Okay. It could be a complete injury or an incomplete injury. Complete injury means complete cut. So, UMN above and LMN below. Incomplete has certain characteristic features. The most important incomplete is Brown-Sequard syndrome. It is hemisection of the spinal cord. Okay. Hemisection of the spinal cord occurs. Okay, guys. Okay. Management wise, after you find out, stabilize the patient, you shift him for X-ray, CT, and MRI, which is the best. And then you start him off steroids. Steroid is controversial, but ideally better to start. So how do you start steroids with prednisolone? 30 milligram per kg body weight IV bolus, followed by 5.4 milligram per kg per hour IV over the first 24 hours. Then if the lesion is there, you will have to proceed for stabilization and decompression. Okay. 30 milligram per kg body weight IV bolus, followed by 5 milligram per kg per hour. Okay. And that is over the first 24 hours. This is still question mark regarding the current studies. But if in the question, if steroid is there, better to answer yes for that. Okay. I hope you have understood the sequence of events when the patient comes to the casualty. What is Asia scale? What is a complete spinal cord injury and an incomplete spinal cord injury? Now we are seeing about, I mentioned one question where the disc is large enough and compressing the entire spinal cord, other middle fibers. Okay, this is the true emergency in spine. Okay, true spinal emergency. There are two types. Okay, cauda equina or conus medullary syndrome. Cauda equina occurs when the large disc is below the L1. Conus medullaris at the level of L1. The difference is you will have bowel and bladder but late after like say 24 hours. Here the presentation conus medullaris itself will begin with bowel and bladder. Okay, both require immediate discussion. Both of them will have motor and sensory, usually asymmetrical in cauda equina syndrome and symmetrical, that means same on both the sides in conus medullary syndrome. But the key differentiating factor is this: bowel and bladder will be early in conus medullaris and late in cauda equina. Okay, both are emergency types. So first we cover the cold spinal cord injuries. Okay, and now we will cover the structural problems of the spinal cord. Okay, structural problems. Okay, the first one which we are going to cover is the scoliosis. Okay, structural problems. We'll begin with scoliosis. What is scoliosis? Yes. Okay. A scoliosis is a three-dimensional deformity in the coronal plane of the spine. That is, in the central plane, when there is a curvature of the spine, curve along with rotation of the spine is called as scoliosis. Hence the term three-dimensional deformity in the coronal plane greater than 10 degrees with the rotation of the vertebrae. The differential diagnosis is the list, that is, there will not be vertebral rotation. Okay, in scoliosis the vertebrae also gets rotated. Classification wise scoliosis, okay, you can classify as congenital and idiopathic. In congenital, there are different things, but most common is the idiopathic. In idiopathic, the most common is adolescent idiopathic. These things can come as questions. Okay, idiopathic is most common. Among the idiopathic is the adolescent idiopathic. So the most common type of scoliosis is adolescent idiopathic scoliosis. Okay, all right. In congenital scoliosis, need not know everything, just understand that there could be either failure of formation or failure of fusion. Okay, failure of formation or failure of segmentation. If there is a failure of formation, you will have something called as hemivertebra. The rest is not formed. So, failure of formation, hemivertebra. In failure of segmentation, you will have something like a block vertebra when two vertebrae seem the same. There is no gap in between them. So usually between two vertebrae you have a disc space. But failure of segmentation, there doesn't seem to be any gap. Okay. These are the two common types of congenital scoliosis. Do not go into the advanced. Okay. Congenital scoliosis, the most common associated condition is the vectoral anomaly. Vectoral anomaly are the vertebral defects, anal atresia, the cardiac defect, then the renal and the limb pathologies. Okay. Now, how do you investigate for a scoliosis? For that, the important question comes as this question. Okay. Normally, identify the angle of scoliosis is given by the Cobb's angle. What is Cobb's angle is? When the curve is like this, upper end of the curve we find and the lower end of the curve we find. Okay. We draw an angle up till 90 degree to that, 90 degree to this, and the intersection of these lines is the Cobb's. So Cobb's greater than 10 degrees is called as scoliosis. Okay. So treatment of congenital scoliosis you determine by progression. Okay. And remember, bracing is not indicated for congenital scoliosis. Okay. In adolescent idiopathic scoliosis, the same thing only. Only the difference is the test. Okay. It doesn't in the congenital stage. So there will not be any formation or segmentation failure. You will start developing it as a positional, and as the weight bear increases, the weight of the body increases, the spine will start to curve. Okay, important tests are, the first test or the bedside test we can do is the Adams forward bending test, and X-ray wise you can use the COPS angle to measure the severity. Okay, COPS greater than 10 is called scoliosis, more than 20 to 30 is mild, more than 30 is severe. Okay. How do you identify whether this curve is going to progress or not? For that, the important is the riser sign based on which question keeps coming. Just know this, iliac apophysis ossification. Okay, see this iliac crest is there. Okay, when one person is fully mature or riser 5 grading, it fully we can see in the X-ray. When only first initial portion we can see, that means stage 1. Okay, inversely proportional, that is, the progression is inversely proportional to riser's grading. So riser's grading is less means the curve has more potential for progression. So in that case, you need to operate them. Okay. But adolescent idiopathic scoliosis, you can use braces. Okay, Boston brace or Milwaukee brace. Okay. Let's look at the few questions that has come from this. All right. Which of the following brace is shown in the given image? Okay. The answer for this question, which has a chin support, full body support, is the Milwaukee brace. Okay, for scoliosis. Look at the other common braces. See, you see the Milwaukee brace has a chin support and full body support. And ash brace means only anterior for thoracic fractures. A Taylor brace is posterior for fractures. A Boston brace is for scoliosis only, but without chin support. These are the important braces. Okay. Milwaukee brace and Boston brace are for scoliosis. One is with chin support, one is without chin support. Ash brace and Taylor's brace are for dorsal spine fractures. One is anterior, and the other is the posterior. Okay. And next question. In the given spine straightening surgery, the screws are fixed to which part of the vertebra? In any spine surgery, not in only straightening surgery. Any spine surgery, for dorsal and lumbar, it is always pedicle screws. For cervical, it is lateral mass screws. So the answer is always pedicle screws. For cervical alone, it is lateral mass screws. A school child was brought to the orthopedics department of Gayansagar Medical College and Hospital with congenital scoliosis. Which screening test will you do? So what is the bedside test we discussed? Adams forward bending test. That is the screening test everyone can do. Okay. On forward bending, if the curve disappears, it is non-structural, only postural. You can give a brace. If not disappears, it is structural, may need surgery. Okay. Yes. Okay. A 65-year-old postmenopausal female came with persistent backache, not responding to conservative treatment. She has a history of heavyweight lifting for 4 months back with progressive increasing pain that worsens on walking and starts radiating down her legs within 100 kilometers of walking. She, however, feels no pain on climbing up the stairs. Okay. The most probable diagnosis is, okay, for this the answer is slight change from this. The answer is PIVD. Now I will talk about two disc pathologies, that is lumbar canal stenosis or disc pathology. See, canal stenosis means the spinal cord passes, okay, between these vertebrae like this, okay. Here the nerve root is going to come out, okay. Because of some lesion, the spinal cord, the vertebrae may collapse front or back, leading to narrowing of the space. This is called lumbar canal stenosis. PIVD means the lumbar canal is passing, nerve root is going like this. There, this is the disc. The disc should come out and press on the nerve. That is the PIVD. In lumbar canal stenosis, you will have claudication. Here you will have sciatica. Okay. Here you will have pain, increased pain on climbing up because you are extending. Okay. Here you will have increased pain on climbing down. This is not specifically with up or down, it depends on the particular nerve. Okay, this is what claudication, the main difference is difference between claudication and sciatica, increased pain on climbing up. So, this is classification of lumbar canal stenosis. Okay, the answer for this is PIVD. Okay guys, not lumbar canal stenosis. So, two important pathologies that can cause lumbar canal stenosis or a disc pathology is spondylolisthesis. Okay, listhesis means, see, all the vertebrae are like this. When one vertebra slides over the other, this is called as listhesis. So, the spinal cord will get compressed like this. So, this area becomes an area of compression. Or it could be even the disc here compressing the nerve root. So, both can occur because of listhesis. Okay. Most common location of listhesis is L5 S1. The nerve affected is always the lower root, that is the S1 affected. Okay. Spondylolysis means only the fracture without the displacement. Listhesis means when there is a fracture plus displacement. Okay. X-ray, you generally take AP X-ray and lateral you take a flexion extension and you get the characteristic Scottish dog sign only in the oblique view and not in the standard views. Okay. The treatment above grade 2, you always do a stabilization and fusion surgery. Remove the disc and fuse it. Okay. The disc herniation alone without listhesis, the most common level is L4, L5 more than L5, S1. It can cause low back pain and sciatica. Okay. Always element type. The diagnostic test is SLR test. Straight leg raising test is the diagnostic test. The types of disc prolapse can be prolapse, that is the initial stage. Then when it comes here, it is inside the annulus. Here it is outside annulus. Here it is a separate fragment or piece. Okay. Treatment is similarly discectomy and you perform stabilization and fusion. Okay. Look at this question. A 30-year-old male is involved in a motor vehicle accident and presents with severe neck pain and neurological deficits. Imaging reveals a hangman's fracture. What is the most appropriate initial management? See, all spine fractures, the moment they come, you will have to stabilize them, give a temporary stabilization before taking for surgery. Okay, so temporary stabilization for any fracture is application of a hangman's fracture is application of a halo brace and a bed rest. Okay, it will not settle just with the cervical collar alone. Okay. Now let us discuss about the common named fractures. Not all fractures is not possible beyond the scope. Please named fractures we'll try to discuss. Okay. A patient on imaging, you see the burst fracture of atlas. Atlas is C1. So C1 is typically, we'll discuss one by one. See, I'll show everything. C1 is the Jefferson's fracture. Okay. See, this is the first neurosurgeon to repeat it. That is the Atlas fracture. C2 is the name fracture is the Hangman's fracture. Okay. Whiplash injury can occur at any level. It is because of hyperflexion, hyperextension injury. Clay-Shover's fracture is the C7 spinous process fracture. It is because of acute flexion. Okay. A chance or a jackknife fracture is usually because of a seat belt type of injury. Okay. It is a type of flexion distraction injury where you see both in anterior a flexion type and posterior you see a distraction. You don't call it as an extension here, you call it as a distraction force. This typical is example of a jackknife or a chance fracture. Okay. Remember the names guys. Chance fracture is a flexion distraction injury. Clay-Shover's is C7 spinous process. Whiplash injury is hyperextension injury. Hangman's is C2. Jefferson's is Atlas fracture or C1 fracture. Okay. All right. Yes. We'll have a small break and come back in 5 minutes. So with this, we have come to end of the clinical based session. So I've covered most of the topics right from basics to the advanced topics of orthopedics, including spine arthroscopy. So next we'll move on to the image based discussions. In the clinical, we have tried to incorporate, always orthopedics is like image oriented. So we have tried to include as much images as possible. So whatever is left out and which can come as a question for you and which has been asked frequently will be covered in the image based session. Okay. I'll get back to you guys in 5 minutes.